Good morning, everybody. Welcome to the Joint Education and Culture, Health and Human Services, and Public Safety Committee meeting to talk about a very, very important issue. We have three panels today. This is to address the rise, the really tragic and unacceptable rise that we would all agree in the use of fentanyl and opioids with our youth. This isn't the first conversation, but this is important in the council context that we're bringing together three committees that this touches on. Obviously, it impacts every committee and all the work that we do here. And we have three panels to talk about it. I want to thank everyone for being here. I want to thank those that are watching. I want to thank all of our advocates. I want to thank my co-chairs, who I'll turn to shortly. Anytime someone is impacted by an overdose, particularly our youth, it impacts all of us in the community. It hurts us, we feel it every time, and we have a deeper and stronger resolve to make sure it doesn't happen again. We've seen, unfortunately, a dramatic increase in the rise of overdoses among our young people and in deaths over the last year. In large part, as we'll hear, connected to the rise in the use of fentanyl and many of these opioids. You've heard the stats, you'll hear them again. We had a 77% increase from last year to this year in overdoses for residents under 21. 48 youth overdoses last year, 11 which were fatal. Already this school year, 5 overdoses that have resulted in death from our MCPS students. We've all been speaking to students in different, there was just a forum over the weekend. We've all been speaking to students in our capacity. My capacity as the chair of the Education and Culture Committee. I've been speaking with students and parents because the number one thing, in my view, that we can do, and a big part of today's session, is get the word out about the deadliness and the ubiquitous nature of these pills and of fentanyl. Some studies suggest that 6 in 10 of these pills are laced with fentanyl, which means the strong chance that if you take that pill, it's going to have something in it that could kill you in one dose. The goal of this session today is to build awareness and to discuss how our county is addressing it from a holistic standpoint, from the public health, from public safety, from the education standpoint, and how we're going to build upon that work that's already been done to have a countywide plan and approach to making sure that we don't lose any more of our children and that the ones that need help get help before it's too late. This is an all hands on deck moment for us. We take it seriously, every one of my colleagues and the county executive and our community members. And so with that, we're going to have a full session. Just a couple of housekeeping remarks before I turn to my colleagues. We'll start with Chair Albernaz and then Chair Katz. Is that we will have about 1 hour for each panel. We have 3 hours. We're going to ask that you move through your presentations, and then we will pause at the end of the presentations and take questions. We'll start with the HHS, and they already know what they're doing because they're here. But before we do that, I want to turn to my friend and colleague, Chair of the Health and Human Services Committee, Chair Albernaz.
Thank you, Chair Jawando, and thank you to my colleagues on all three committees, as well as colleagues who are not members of these committees, but very interested in this topic. So I started my professional career a little over 24 years ago in the youth development space, and I worked for an organization called the Latin American Youth Center in DC, and that coincided with the rise in really historic gang violence that we were experiencing as a region here in our community. There had been several high-profile murders, and the gang problem was wreaking havoc, devastating families, and devastating our entire communities. It was a complex issue that required a multi-layered approach, and I was proud then of the systemic approach that not just Montgomery County, but the entire region took to addressing an issue that made me believe if we were not addressing it in a complete way, we could lose a generation of kids. I sensed then desperation among families, I sensed desperation among youth, I sensed desperation among the street outreach workers who were working with youth, and we did something about it. We established a blueprint that included a prevention, intervention, and suppression strategy That included the development of the gang unit within Montgomery County Police. It included additional resources. It established the street outreach network, which has been expanded within our Department of Health and Human Services. We created communication tools for parents so that there truly was no wrong door. And it created this positive youth development approach that focused even more on the prevention and intervention aspects of that issue in a way that truly made a difference. Based on the conversations I've been having with parents and children and providers and folks that are directly involved in the community, I'm feeling that same sense of urgency that I felt 20 years ago. And feeling once again that if we don't take an urgent systemic approach to addressing this issue, we could once again lose another generation of kids. Now, I see out in the audience remarkable leaders who are working day and night and feel the same urgency that I have and feel the same sense of some days feeling overwhelmed. But this is an opportunity for us during this session to check in. And we know there is a lot of work happening in each of those respective categories, and that each of the respective agencies that will present today have been working day and night to resolve this issue. We also know this committee session alone is not going to resolve it, and that we have to look in the mirror ourselves to determine whether or not the programs and services that we've established are working with fidelity, are accessible, and acknowledge that there's much more that all of us can and should do. So I will be looking at today's discussion through the lens of deep appreciation to those working hard in this space, but an acknowledgement that we cannot do this alone. DHHS, MCPS, MCPD, our community-based organizations and partners, and certainly parents, need a level of assistance that rises to the occasion. I'm committed to doing that, and I know my colleagues are as well. And this may take resources, this may take policies, but we have to have, as Councilmember Jawando mentioned, an all-hands-on-deck approach. We must educate our public about what's happening. We must intervene for students that are in crisis. And we've got to go after the people that are selling these kids these drugs in the first place, and go after them hard. So that is where we are today. And I appreciate the opportunity to establish, from my perspective, some context for this conversation. Thank you. I yield back to you, Mr. Chair.
Thank you, Chair Katz.
Thank you very much, Mr. Chair. And I'd like to also thank everyone for being here, and for all the presenters for being here as well. And preventers, that's a good, I didn't mean to say it, but it's the right thing to say. Because we're working together in this crisis. The fact that all three committees are discussing this topic together is a demonstration for concern and need for all departments, all agencies, to continue to work together for solutions. But today is far from the first day, as has been mentioned a couple times already, that we've had these discussions. And today certainly will not end our discussions. I want to publicly thank the legislative analysts, Ms. Johnson, Ms. Farag, and Ms. McGuire, for putting together an extremely well thought out and thorough packet for us to review. On page 2 of that packet, it says, and I quote, "Today's briefing will be a broad discussion on the strategies among county agencies toward reducing and eliminating opioid and fentanyl exposure and overdoses for youth in the county. By working together, educators, emergency responders, health experts, community partners, government, and families can provide the critical supports that help keep our children informed, healthy, and safe." That says it all. Thank you very much, Mr. Chair.
Thank you. All right, we're going to jump right in to our first panel. We have Dr. Keisha Davis, our health officer, Dr. James Bridgers, our Dr. Rolando Santiago. I don't see him. He's not here today, so from HHS, but I'm sure you two can cover. Mark Hodge, if you want to come up as well. Mark, School Health Services Administrator. Sarah Rose, Operations Manager, Local Behavioral Health Authority, and Ben Stevenson II, Prevention and Harm Reduction Manager. And you all have a presentation, correct? Okay. All right, put your mic. Start with that, and then what we'll do for colleagues is we will pause after the presentation and take questions on this panel. So just text me or let me know if you have a question. So I'll turn it over to you, Dr. Bridges. Thank you.
Thank you, Councilmember Jawando, and good morning. Thank you for having this joint committee session. Councilmember Alvarez, there is a need for a sense of urgency. And so all of the community partners that are assembled here today have been working very diligently to address that sense of urgency, to look at a multi-level approach, which includes primary prevention, education and awareness, secondary prevention, harm reduction and treatment. Mr. Stevenson, Mr. Hodge, and Ms. Rose will speak to some of that, and a tertiary prevention, overdose reversal, grief, and loss support. But these multi-level approaches need to be culturally appropriate. They need to be culturally humble, and we have a lot of work to do in that space. I will stop there with those opening remarks. Unfortunately, Dr. Santiago had a death in the family and couldn't join us today, but we have a very strong and resilient team. And in that regard, we will present the facts, the data, and provide recommendations for a way forward that we can have a discussion about, a frank and open discussion. I'll stop there and turn it over to Dr. Davis to go through the presentation.
Thank you. And just, Dr. Davis, for you, I just want to acknowledge School Board Member Julie Yang demonstrating the strong support cross-agency. Thank you for being here. Dr. Davis?
Thank you. Thank you, Dr. Bridgers, and thank you, Council, for bringing us all together for this very important conversation. You can go to the next slide. I want to start us off by just giving a little bit of background on opioids, what they are, and kind of the state of the affairs where we are right now. So opioids are a class of drugs that are often used as painkillers. Comes from the opium poppy that works with the opioid receptors in our bodies. And they include prescription medications such as hydrocodone, oxycodone, morphine, codeine, methadone, fentanyl, as well as the illicit drug heroin. They are all within that same class of opioids. They work by binding onto that opioid receptor that controls pain, pleasure, and emotions, in addition to the regulation of breathing. Go to the next slide. 136 people die every day across the country from an opioid overdose, and that number is probably a little bit old. Some of the effects that we see from opioids: euphoria, pain relief, relaxation, confusion, sedation, drowsiness, pupillary constriction, nausea, vomiting, constipation, slowed breathing. And these are the effects that we see in overdose. So when someone has overdosed, they are often very sedated, their breathing has slowed, you may see nausea, vomiting. Those are the effects that we see when someone is potentially unconscious, and what would suggest us to suspect an opioid overdose. Fentanyl, and that's why we're really here today, is a powerful synthetic opioid. It does not occur naturally, it is made synthetically. It is 50 times more powerful than heroin, 100 times stronger than morphine. It's illicitly manufactured, comes in a variety of forms, powder or liquid. Often that powder can be cut with other things and placed in pills. In the liquid form, it can be mixed with other things as well. Part of the reason why it is so dangerous, it doesn't have a distinct smell or taste, and can easily be added to other street drugs, heroin, and counterfeit pills. Its high potency greatly increases its risk of death, especially for a person who has been, who is not aware that they are consuming fentanyl. You can go to the next slide. Just to demonstrate, what that looks like. Just 2 milligrams of fentanyl, which is equivalent to about 10 to 15 grains of table salt, is considered a lethal dose. Producing illicit fentanyl is not an exact science. You can go back to the previous slide. DEA analysis has found that counterfeit pills ranging from 0.02 to 5.1 milligrams, which is more than twice the legal dose of fentanyl per tablet. So folks who are putting fentanyl in pills, it is not equally distributed often throughout that pill. When you go to the next slide, you can see how fentanyl is in some ways being marketed to look like candy, rainbow colored chalk, brightly colored pills. In 2022, in August alone, DEA seized brightly colored fentanyl pills from 18 states, including Maryland. We're also seeing fentanyl quite substantially within counterfeit pills. And so they are mass producing fake pills that look like OxyContin, Xanax, Vicodin, amphetamines. And so this is an important distinction because we have persons who may be specifically looking for fentanyl, maybe looking for those brightly colored pills, and we also have people who are looking for something that is not fentanyl. So they maybe thought they were taking a Xanax or an Adderall, which they probably shouldn't have been taking, but they weren't intentionally looking for fentanyl, and those medications are laced. We're also seeing that a lot of illicit drugs, cocaine, methamphetamines, are now being laced with fentanyl, which makes them more deadly and more addictive. Next slide. So I want to show some of the current data trends. And there is some good news, actually, when we look at illicit drug use. So the Youth Behavioral Risk Survey that is done every year looked at the period from 2011 to 2021, actually showed a decrease in substance use in high school students. The percentage of high school students using cannabis decreased overall during that time period. And the percentage of students across racial and ethnic groups who drank alcohol decreased from 2011 to 2021. We did see that there was about the same rates of misuse of prescription opioids during that time period. And while we did see that decrease in alcohol use across racial and ethnic groups, there are some populations that we do want to be more worried about. We saw female students and LGBTQ students reported that they were more likely to drink than their peers. It's an important distinction because while we are not seeing an increase in illicit drug use, alcohol use across the board, what we are seeing is that the drugs that they are using are more dangerous, more lethal, and more likely to be addictive because of the addition of fentanyl into that drug supply. When we look at this, the rates of opioid use, opioid poisoning is in the blue, and opioid related, these are emergency room visits. Opioid poisoning is inclusive of overdose and intoxication in the 5 to 17 age group, and you can see that dramatic increase in opioid use. I do want to just...
This is local data.
This is local Montgomery County
Thank
data.
you.
I do want to caveat, you'll see for several years they are the less than 11. So Maryland and Montgomery County advised by this as well. We don't report individual numbers when they are less than 11 because we want to protect privacy, especially in youth. When they are such small numbers, it becomes easier to identify who that person might be in the community. So out of patient privacy as well as especially in regards to youth, we don't report less than when it's less than 11. Go to the next slide. And so I want to frame this as part of the bigger problem. What we are seeing with opioid overdose and fentanyl is really part of a broader mental health issue, mental health crisis that we are seeing. When we think about why might our children be reaching out for pills, whether they be prescription pills or illicit drugs, are they crying out for something? And making sure that we are addressing the entire problem and not just, the fentanyl issue at the top. What we are seeing in overdoses is really just the tip of the iceberg in terms of that broader mental health issue. And so I want to frame this, how we think about things in public health, is really a primary, secondary, and tertiary prevention. Primary prevention is what we do for everyone. That is how we are reducing the use of drugs amongst youth and adolescents, which really focuses on education and awareness. Secondary prevention for those who are either already using or at high risk for using, really looking at harm reduction and treatment. And then that tertiary prevention, when an overdose has already happened, how are we making sure that there are resources to treat for overdose reversal, such as naloxone, also known as Narcan, and also grief and loss support in the unlikely event that someone should pass, as well as addiction and treatment in that when overdoses happen. So you can go to the next slide. I'm going to turn now to Sarah Rose, who's going to talk about some of the programs that we already have in place through DHHS to address drug use.
Thank you. And thank you all for coming together and talking about this very important topic. This talking about adolescence and substance use concerns has been a big focus for us and within HHS for many, many years, and particularly now with the the increase in availability of fentanyl on the streets and access that our kids have to fentanyl is become extremely deadly very quickly. So we can go to the next slide. Within the MCPS Partnership and Community Services, there are multiple programs, and we have within school nursing. All of the high school, middle school, elementary schools, and community schools are staffed with a registered nurse. There are health techs in all of the schools, and the nurses and health room techs are trained in Narcan administration, and Narcan is available in all of the schools. The school health and wellness centers, there are 15 schools that provide primary and acute care and sports physicals. In addition, the Bridge to Wellness and School and Community Youth Services, there's mental health, care management, youth development services in 19 high schools. And the goal is to work towards wellness centers available in each high school in the future. The positive youth development programs include gang prevention, the street outreach network program, building social and emotional skills, and there's quite a few other programs within the positive youth development programs and our community partners. BeTheOne.org is a substance use and suicide prevention campaign that was started in 2017. And this campaign is targeted towards Montgomery County youth. This website provides information about what young people can do to help a friend or a loved one who's experiencing either suicidal consideration or if they're actively using substances. And the steps are to ask, to keep them safe, be there, help them connect, and to follow up. In addition, the BeTheOne.org website provides lots of resources available in the community to get connected for treatment and to understand more symptoms about mental health and substance use concerns. Last year, associated with BeTheOne.org, we have started a youth ambassadors program. We are currently in its second year, and we have a group of high school students representing multiple high schools across the county. And the young folks are giving a voice to the county, and we provide them with leadership skills development, and we provide them with information about the risks and the dangers of substance use, talk with them about information about mental health, and they share that information with their peers as well as the community. We also have the Adolescent Substance Use Prevention Program, or ASUP, and this program provides evidence-based prevention education groups in schools, primarily, as well as in the community. And we provide the life skills curriculum, where it talks about how to develop healthy coping strategies and increasing their awareness about the risks and dangers of substance use. ASUP also offers presentations and community outreach. We were present at the Family Fentanyl Forums, and we provide a lot of information and resources to the community. Next slide. In addition, there are multiple community awareness campaigns, the social media campaigns regarding Know the Risks MC, as well as BeTheOne.org. We share information with the community about the dangers and the risks of fentanyl. We had a PSA that was run last year talking about fentanyl and the Go Slow campaign, and it was very successful and was actually nominated for a local Emmy. And we provide information and printed flyers, posters, and stickers to youth and adults, again, about the dangers and the risks of fentanyl, awareness that fentanyl is here, and the concerns about how deadly this drug is. We offer DTERA drug deactivation system. There are pouches of medication as an alternative to just throwing away unused prescription medications. We oftentimes will bring these pouches out into the community at outreach events and encourage parents to discard of unused opioids and other prescription medications this way, rather than dumping medications down the toilet or allowing medications to just be out and available inside the home where it could be accessible by youth. We also participate in the Montgomery County Prevention Alliance, and this is a coalition that addresses substance misuse prevention. We have a lot of advocates in the community, and we work towards spreading awareness about substance use concerns and work to address and mitigate those concerns and risk factors. In addition to the prevention strategies for the general population, we also have early intervention screening and treatment programs, as well as harm reduction in the county. The Behavioral Health and Crisis Services offers free substance use screenings and mental health screenings for any youth who lives in Montgomery County. This is called the Child and Adolescent Assessment Services. It is located in the Crisis Center, and there is a team of licensed clinicians who works specifically for young people. They offer free on-site drug testing and make recommendations for the appropriate level of care, and also make recommendations for support services. This service is also available for any youth in the county, regardless of insurance coverage and regardless of language spoken. The local Behavioral Health Authority, which is a part of Behavioral Health and Crisis Services, provides oversight of a variety of contracts for treatment providers who have treatment and recovery programs for youth in the county. For treatment, our contracted provider is Suburban, and they run an addiction treatment program for youth, and they also provide early education as well as support groups for parents and caregivers. Their parent and caregiver support group is available for any community member. They don't need to have a child enrolled in their program in order to participate. Journeys for Adolescents is run by Maryland Treatment Centers, and they provide the intensive outpatient treatment program for our youth in the county, and they offer intensive outpatient treatment as well as they're licensed for outpatient treatment as well. We have a contract with Shepherd Pratt to run our Adolescent Recovery Clubhouse, which is called The Landing. The Landing is co-located with the Recovery and Academic Program located in Gaithersburg. They offer pro-social activities for youth who are in recovery from substance use. So after a young person has completed treatment or who is determined and dedicated that they will maintain their sobriety, they're able to engage in these support services, and they do lots of fun activities out in the community and connect with other youth who are also committed to their recovery. I will also say, in addition to our 3 contracted providers, there are also multiple other treatment providers who offer substance use treatment services in the community. We have a total of 10 providers who are located in Montgomery County who work with youth specifically with substance use concerns. Several of them are for private insurance only, but the majority of them also accept Medicaid. And for the harm reduction and overdose reversal, as well as the grief and loss support, I'm going to turn this over to Ben Stevenson.
Good morning. Next slide. As far as harm reduction is concerned, we have an array of initiatives that we're implementing in the community. Specifically, one that a lot of people know about is our Narcan training and distribution efforts. We provide recurring monthly training within the community as requested. We actually have 2 standard monthly trainings that are virtual, one the second Wednesday of each month, and then the other is the 4th Tuesday of each month, which are virtual trainings. Once a person takes that training, they can receive a kit by it being mailed to them, or we could actually set up a time for them to either come up and pick up at one of the HHS offices, or we'll even deliver it. I have staff that actually delivers Narcan kits as well. We've recently, with the recent surge and requests of Narcan kits and training, we've recently added a third Saturday of each month training in person, which is currently being hosted at the Crisis Center every third Saturday of each month. And we're in the process of actually adding a additional in-person training at the Crisis Center, probably the second Saturdays of each month, just to try to meet the demand of all the requests. In addition to those, we're also we've trained a lot of law enforcement officers throughout the county. We trained all of the school health nurses throughout the county. In addition to working on a partnership with Montgomery County Department of Transportation, we were training all the bus operators in the county to understand the signs and symptoms, as well as being able to respond to an overdose. Each of our kits are equipped with 2 doses of Narcan. In addition to that, we provide face shields for rescue breathing, which is an important piece for saving a person's life, as well as information within there around resources, safety gloves, and things like that, just to try to make sure that everyone has everything they need to respond to an overdose. In addition to that, we also have a syringe services program in the county, which provides supports for persons who are dealing with substance use disorder. So we provide harm reduction supplies to clients who might be dealing with substance use disorder, try to get them connected with additional services and supports. Within that program, we're able to provide free wound care to any individual who's dealing with substance use disorder, as well as free HIV testing. And we work in partnership and collaboration with our public health services office. If a person tests positive for HIV, we were able to make that referral and things like that. In addition, we also try to connect them with, clothing, housing supports, food services, and things like that, just to try to make sure we are wrapping around services to, hopefully foster a partnership or build rapport with that client to eventually get them to a place of pursuing their treatment and recovery. And then in addition to that, we also do fentanyl test strip distribution, which we work with a lot of community partners, community-based service organizations, that we actually just provide them boxes of fentanyl test strips, and they just distribute them to clients and people in need. In addition to what I mentioned about Narcan training and distribution, we actually provide all of the Narcan kits for fire and rescue for leave behind. So if a person accesses or if a person overdoses from an opioid, fire and rescue will actually leave a kit behind for that family or for that victim, for just in case they experience that overdose again. And then also we provide fire and rescue with additional kits, so that if anyone in the community wanted to have a kit just to be prepared, they can actually go into the fire station and request one and receive a kit. So we're actually in the process of working to increase the number of Narcan kits we provide to fire and rescue, just so that if anyone comes in, they're able to access that kit. And in those kits, we actually put fentanyl test strips as well, so that people can access those if they need them. Next slide. As far as Narcan training and distribution, we definitely have seen an increase in interest. We've been doing Narcan trainings for probably since 2014, 2015. When we first started doing them, we would range in numbers of participants in each training between 20 to 30 people. Probably the last year and a half, we might have had maybe 10. But starting in December, I'll say once the memo went out to MCPS parents from Dr. Kapunen about the dangers of fentanyl, our trainings have been at capacity at 40 each training since December. And if you look at the chart there, you'll notice just for the first 2 months of 2023, we've pretty much exceeded what we did in 2019 as far as training and distribution just in 2 months. So definitely notice that it's important to continue the resources in that space, just to make sure that people have the information and the access to the kits and things that they need to save a life. Next slide. Also, we recently, within our overdose fatality review team, they received some funding from the Office of Population and Health Improvement to provide grief support and loss for family members who lose a family member to overdose. These groups are happening once a month as of right now. It's currently in a pilot phase, and in addition to receiving that grief support group, they're also free 3 free counseling sessions to those families who might have lost someone to an overdose as well. So you notice there the grief support groups are bi-weekly. We provide ongoing information and support, as well as, if they have other family members that may be struggling, that we may receive, referrals to treatment and recovery and supports and things like that as well. So definitely an array of services from the harm reduction space, prevention space, as well as from the support space as well for families. And next slide. Okay. And thank you for listening to our presentation. So.
Thank you very much, and that was a lot of information. It's very important. I appreciate, Dr. Davis, the really powerful images that you use there, and also just laying out the different levels of support in that. I'm going to ask colleagues, several have reached out, that we limit our initial exchange here to 5 minutes so that we can make time for the next panel. And so if everyone speaks, that would be about 35-40 minutes, and I'm assuming everyone will want to speak. And then we will go to the next panel, and I understand MCPS has a little shorter presentation. So as with all good things, when you organize ourselves well, we will have more time at the end. So I would ask that you stay even after, because we likely will come back to you and have an interconnected conversation towards the end. I will model good behavior and ask 2 quick questions, and then turn to my colleagues. So talk a little bit about which youth populations are most at risk. You mentioned that a little bit, Dr. Davis. Obviously, we're focused on equity here in a big way, and we want to make sure that we have the appropriate responses based on who's being impacted. We want to help everyone, obviously, but we want to make sure that we are targeting our response to where the need is.
No community is being left out, unfortunately. In terms of where we're seeing this, we're seeing it across the county in all of the different high schools and all of the different communities, the rich and the poor and the black and the white. And so, I don't want to give the perception that this is only a problem in a certain community, and it really does span the county. I don't know if you want to go into a little bit more of the zip codes, but I do want to highlight that the resources that we have available are available regardless of ability to pay and in multiple languages.
And since you teed that up, that was going to be my second, but you can address it. The multiple language issue has come up multiple times. I know with me and with others in the trainings that you're doing, do you have Spanish-speaking, other language-speaking Narcan trainers? If not, what are you doing to remedy that? Could you address that in your answer as well?
Yeah, so for quite some time we did have some challenges in regards of acquiring a Spanish-speaking trainer, but we have addressed that. We've found partners within DHHS as well as outside of DHHS who are willing to actually translate our Narcan training into Spanish, as well as facilitate the training into specific Spanish. We already had a lot of materials that were translated into Spanish around safe storage and disposal, around identifying the signs and symptoms of an overdose, around administering Narcan and things like that. But I think for us, we had some challenges in regards of finding speakers who were willing to actually do the training. But we've addressed that issue. We actually have the ability to provide the training specifically in Spanish to Spanish-speaking residents, and we're looking forward to doing that. We did have that in the past, but the person that was in that position who was able to do the Spanish-speaking Narcan training transitioned out, and that was around the time we weren't really getting requests or finding people within our Spanish-speaking population that were actually requesting the training in Spanish. In addition to that, we also utilize the language line for interpretive services from time to time. I think we only had to do that maybe once or twice since 2014, 2015 for persons that speak Spanish to make sure that they understood the material and things like that. So we definitely always try to keep culture in mind in regards of trying to reach all populations within the county, just because we know it's so diverse. But I think we're in a lot better space now to address that.
Okay, and I have a minute and a half left. Do we have enough Narcan? Do we have enough capacity to train people? Do you need more resources for that?
I will say we did run into some challenges of supply because we get our supply free from the state, just like every other jurisdiction. But we've been able to find some county funds that were available for us to order additional Narcan. I think it's important to continue to put resources in that space just to make sure that, you know, maybe supply might exceed demand, but one thing about Narcan, it does expire. So it's important to, you know, not have Narcan that's just sitting in a closet or in a warehouse expiring, because then that's a waste of, you know, county dollars and things like that. So I would just say what we've tried to do is make sure that when we get requests for trainings, we try to order enough Narcan to equip or to address all of those trainings and things like that. And then we've tried to be very equitable because we could probably, you know, for instance, all these fentanyl forms that we're doing, we could possibly, you know, equip all of those trainings with Narcan, but then there might be another group in another part of the county that may need Narcan, and we don't want to run out totally. So we're just trying to strategically provide Narcan so that if we provide enough, and then, you know, we also have a QR code that people can scan. And once they take our Narcan training, they scan the QR code and request a kit, and we'll mail it out to them. So we're actually trying to make sure we, you know, exceed the demand with the supply. So
Okay, well, keep us posted. That's obviously something we don't want to run out of.
Yeah.
Dr. Davis, did you have something to add? Or-
no, and then they can also get it from the fire stations as well if they're not able to get it at the training. So.
All right, appreciate it. I'll pause there. We're going to go to my co-chairs, and then we will go to other colleagues. Councilman Robinos.
Thanks, and we're there will be a lot more to cover than we have time to cover today, and so there will be a lot of follow-up questions, again, with the acknowledgement that we need a systemic approach to addressing this issue. And as I stated in my opening comments, I know a lot's being done. We've got programs and services, but there is undeniably a question and concerns that have been raised about the cultural humility and the availability of these programs and services and where to find them. And it's not just enough to translate, as we all know. We have to go much deeper than that and work truly with community-based organizations, including faith leaders, who have the trust of our community, and often is where they go to seek information, not from government, for a lot of reasons. So, Dr. Bridgers, first of all, I appreciate your willingness to step forward and act in an acting capacity as well for our incredible Department of Health and Human Services. A number of programs were enumerated. How do we track both qualitative and quantitative outcomes for those programs? How often do we track those qualitative and quantitative outcomes? And in a follow-up, I don't expect it in 5 minutes or less, but I would love to see both the breakdown in level of participation, the demographic breakdown in level of participation, acknowledging, and I can confirm, this is impacting every zip code in Montgomery County. But the response needs to be commensurate with the needs of each of those individual communities, and we have to acknowledge that some communities need additional level of support that others may not. But it's a problem everywhere. But if you could just speak to that at a high level, I'd appreciate it.
Sure, thank you, Councilmember Albernos, and we've done just that. And so while our behavior health and crisis services team can give you the data, both the qualitative and quantitative breakdown, we formed a consolidated effort across health and human services because it's not specific to behavioral health and crisis services, so it impacts the entire agency. We completed a SWOT analysis to look at those strengths, weaknesses, opportunities, and threats. Again, thinking about the opportunity that you just referenced as far as our faith-based community. So looking across all of our key stakeholders and how they could be support. It has to be culturally appropriate. It has to be culturally humble, and we need to really look at that. Moving from a deficit model, but from a strength-based model. We really need to look at the capacity and capability that we have within HHS. And one of the strengths of having a joint meeting is just to talk about that capacity and to talk about those needs and to look at a gap analysis and also look at quality assurance to make sure that programs that we have are effective. To do, for example, a model of a plan, study, do, act. One of the questions that I posed to Ms. Rose was whether or not we really went into our SBIRT model, screening, brief intervention, and referral to treatment, that was crafted under the Substance Abuse and Mental Health Services Administration. Folks don't know, but it has to be family-based. We talked earlier about an individual effort, and yes, harm reduction is key, but we really need to look at those family units and the impact that it's having at the family level as well. And through that consolidated effort, Mr. Hodge is at the table, and I've asked him to lead that effort, but we really need to look at HHS. And then the last piece is our partners. We have great partners in our Montgomery County Public Schools and our Montgomery County Police Force. And just to look realistically is how we can integrate that collaboration to be more effective. So that's where we are.
Thank you. And Ms. Clemens-Johnson, we'll work with you to follow up with the HHS team to break down each of those incredible programs that you enumerated, and just see where we are and check in on that. Last question for now is, and this crosses over into MCPS, and you mentioned those partnerships, and I know it's a little awkward because MCPS is going to be presenting right after you all, and some of this may be covered in their presentation. But the notion of referrals and how we are communicating back and forth between those folks that are on the ground providing services has never been more important. And I know it's been an ebb and flow over many years in how and when we communicate that information. But when a student, for example, has been absent for an extraordinarily large number of days, who is that information being communicated to within HHS? Where is the follow-up? And just one of hundreds of examples of where there is crossover between both agencies. So I would, as a follow-up, love to talk about how that interaction is happening, how we can strengthen it, and acknowledging there are 300 vacancies or more within HHS right now as we speak. And so people are exhausted. And there are many vacancies within MCPS as well. And so part of the systemic approach is going to have to be shoring up, making sure we have the appropriate infrastructure within our agencies if we're going to have a prayer of addressing the issues that we're seeing in our community right now. We have to acknowledge that. So we'll follow up with you on that, but I yield back to you, Mr. Chair.
Thank you, Chair Katz.
Thank you very much, Mr. Chair. Again, thank you for your presentation. We're using the term crisis, and it truly is. You mentioned that Narcan has an expiration date, which a couple of years ago, I guess, before the pandemic, I went to one of the classes, the courses. But I also remember saying hearing that it can't be left in a hot car. There's certain things that even if someone wants to do the right thing, they have to figure out how to do that right thing. And hopefully there's good information on the kits that explain all that, that remind people that how we do that. I'm assuming that's correct, yes?
Yes, it is, but we also emphasize that in the training to recommend against leaving it in a car for, the extreme temperature changes in the region. We recommend if you have like a go bag or a purse, just put a Narcan kit or, Narcan in there, and just possibly keep it on your person, take it in the house, things like that. So we do educate on that.
I appreciate that. You mentioned that Narcan obviously is 50 to 100 times stronger than heroin, but excuse me, I mean fentanyl. On Narcan, how fast do you have to give the Narcan in order to correct that overdose?
The recommendation is immediately. I don't think there's been a specific time frame, and I'm pretty sure Dr. Davis can maybe talk better about when the brain and the other vital organs start to shut down. But I think when you recognize that the person is experiencing that overdose, it's immediately. And then after you administer that first dose, you allow that 1 to 3 minute window to take effect, and you're providing a rescue breath for that person. If they haven't woken up, you give them that second dose of Narcan. And it's always important to contact EMS because there's been instances where a person needed additional doses than the 2 that are in the kits. So we just want to make, and they might have some other complications. So you want to get EMS there to make sure that they get the support that they need.
Okay. And I know we're under time crunch. I'm going to stop with this one. But when we know, and I saw a thing on the documentary on the dark web and how this is really an international type of concern for the supply. Are all departments working together to figure out, to Councilmember Albernaz's earlier statement, where this supply is coming from? Are all departments working together?
I know we're working in partnership through the overdose intervention team with law enforcement, with fire and rescue, with other community agencies and county agencies and things like that to not only look at the supply, where it's coming from, but also look at where overdoses are occurring, and see if we can make sure we focus resources in those different zip codes within the county to try to address the issue, bringing, not only Narcan, but also education, awareness, just because, it's not it's not an issue that's isolated by, race or demographic or, socioeconomic status. It's impacting everyone. And so we want to try to make sure we reach as many people in across the county, make sure that they're aware of the issue, aware of what's the fact that, 9 times out of 10, any prescription pill that a person gets off the street is laced with fentanyl nowadays.
Absolutely.
Even clients within our SSP indicate to us that it's hard to find anything that doesn't have fentanyl in it anymore. So, making the community aware of that is important, just because, just like I think the DEA said, one pill can kill, and that's actually true.
Thank you very much. Thank you.
Thank you, Mr. Chair, and thank you all for modeling good behavior. Councilmember Lukey.
Hi. You mentioned the adolescent substance use prevention program and that it was for at-risk individuals. How are you determining who is at risk?
We work in partnership with MCPS, so we have great relationships and communication with our partners there. And when a particular school has concerns about groups of students who are either actively using substances or maybe are talking about using substances, or there's concerns, truancy issues, things like that, then they can contact us and ask for us to come in. We also we provide information to the schools about how to get them connected to the Child and Adolescent Assessment Services program for screenings if they are actively using, because oftentimes once a student is using substances within the walls of the school, that oftentimes there does need to be treatment and more than just the prevention education.
And so for that, are those the screenings that you're talking about that are done at the crisis center?
Yes.
Okay. And so typically for those folks who come to the crisis center to undergo those screenings, are they coming with a parent or guardian? What percentage, or what percentage of folks are coming to the crisis center for those screenings as a result of referral from the school system versus parent or guardian bringing them on their own?
So there's a mix, and it fluctuates from month to month, but we do keep track of information in terms of where students are being referred from. They don't always necessarily tell us the school sent us. Parents sometimes will call and say, I would like to have a screening for my child, and they can come just as a self-referral. Sometimes the schools will provide us that information directly and say, we're making this recommendation for the student to come. Most of the time they are coming with their parent, and oftentimes it is, if a parent has concerns about their child's just behavioral health in general, if they're not quite sure what's happening, if they're just seeing some changes or some symptoms, either of mental health or substance use concerns, then they come in and they can kind of get some help and more information about the full picture about what's happening with their child.
And there were two, the Suburban Addiction Journeys for Adolescents and Adolescent Clubhouse. So what are the what's the availability for those programs? How many individuals can receive programming at a time?
So right now, all three of these programs have no wait list. They're all available. They've actually, have had relatively lower numbers since the pandemic of participants, and so there's currently no wait list for any of those programs. They're not at capacity.
What is the capacity though for each of those?
It depends on the different programs. They have usually about 20 to 30 students, youth in at a time for different programming that allows for groups, and they also provide individual and family therapy sessions as well.
Okay, thank you.
Thank you, Councilmember Lukey. Great thing about this is you asked questions that we all were going to ask. I was going to ask a similar question, but ran out of time about the capacity. I think just that point's important, though. If there is capacity, we know there's need. There's something not aligning with how we're getting the information out, either in a culturally competent way or people knowing about it. So we need to work on that, obviously. Councilmember Fanny Gonzalez.
Great follow-up with the previous questions. Let me tell you a story. Since I got elected in December, I've been receiving call after call of people in my district. I live in District 6. It's there between Forest Glen and Aspen Hill, where youth have died with overdose. I get a text message from the police every time something bad happens in my district. And I'm the type of person who, when I hear that something bad happens, I go and meet with a family. And I have met with every single family who had either have a child who has died or was in a serious condition. I met with the mother of the 15-year-old girl who passed in December of an overdose. And when I asked her, you know, what was your experience dealing with county government, she had a lot to say and nothing positive. She told me that she begged to ensure that her child would be in a rehab center, but there were no beds for her child to be there. And that was not the first story I heard. Then on Saturday, we were at Northwood High School for the fentanyl event, and there was a Spanish-speaking section with, I don't know, I think we were over 50 parents were there, all Latinos in Spanish, parent after parent, telling their stories how their children could not find help. That the crisis center would just give them a referral, and that's it, because there was not a place for them to stay and clean themselves. So we have kids who are dealing with mental crises, as somebody mentioned, but we don't have a place to help them. That's what I'm hearing, which is different from what you're saying. So I just want to put that out there, that as Chairman Albornoz mentioned, it's not just about translation. It's about really doing outreach and talking to community members and giving help, especially knowing that in our low-income communities, people are working 3-4 jobs. They're trusting that their kids are okay in schools. And that's not the case. Putting that up there, that's all.
If I could, I thank you for sharing that story, and I agree. There needs to be more awareness of the current resources that are available in the community, and there needs to be additional helps and supports too. Again, this is why this conversation today is so impactful and so helpful, because we really do need all hands on deck. In the past, about 7 years ago, the state of Maryland used to have 3 different residential treatment programs for adolescents, all 3 of which have closed. Over the years, there have been a lot of changes. There's just system-wide changes. 2 of the residential programs closed in 2017, and the 3rd one closed in 2019. So currently in the state of Maryland, there is not a residential treatment program for adolescents. When there are detoxification or withdrawal management programs that are available outside of the state that we can make referrals to. But yes, it is very much a concern.
Thank you, Councilmember Fanny Gonzalez. On that point, Dr. Bridges started saying we were going to have recommendations. That sounds like a really solid recommendation to Governor Moore and Lieutenant Governor Miller, that we need facilities for adolescents. That needs to be in the budget this year. We need to push for that, and ask our staff to follow up about. I think we should write a letter to the governor asking in our state legislature asking for that. That story should never happen in our county. There should never be where we have nowhere to go. And that is also true at, obviously, so many of these things are connected. If you're dealing with a mental health challenge that you then self-medicate and you didn't get help on the mental health challenge because we don't have capacity either at school, in the community, these things layer on and we get to these serious situations. So, Dr. Davis, go ahead.
I'll just comment to that. We do have recommendations, joint recommendations with MCPS that we'll go through together at
Great.
the end. But
Okay.
one of those is around having a inpatient facility, but also to your point around co-occurring substance use disorder treatment
Co-locating.
with co-occurring substance use
Yeah.
and mental health treatment facilities. We have those for private payers, but we don't have those for public payers for our Medicaid patients, where you can get, so often the depression, anxiety, another mental health issue is what is driving the substance use issue, and being able to treat those together concurrently is really important.
Thank you for bringing that up. Councilmember Sales.
Thank you, Mr. Chairman. I appreciate the panel's expertise and the abundance of information that's been shared, the abundance of work that's been done in the prevention and education space. I am curious about the programs that exist and the coordination between Montgomery County Police Department, MCPS, and Montgomery County Fire and Rescue Services. And I'm sure that'll be a good question to summarize the end of the discussion. But I wanted to know, you mentioned, I think, about 3 programs. How many programs exist in HHS now to address the prevention and awareness of opioid abuse? And how are these programs evaluated? Does HHS partner with MCPS to publicize any of the programs that were shared with us today? And how many students are taking advantage of these training sessions? And then I'm asking these questions because if we have ambassadors at these programs where we're hearing about incidents of overdoses, are there some tweaks we can make to these programs for our ambassadors, or do we need to deploy ambassadors at strategic locations? So if you want to, anyone who wants to speak to that, thank you. No, that was a lot.
Okay, I'll try to cover all of that for you. We do have an array of programs that are funded through the state, come through HHS, and then we have county vendors that are actually doing the work. So, for instance, one program specifically is our Dare to Be You program, which is a parenting program for parents of preschool age youth, so ages 2 to 5, and it teaches some resiliency parenting skills, hoping to reduce or delay the onset of substance use by adolescent by building up those protective factors within the family. That program is only able to reach 4 schools a year. 4 elementary schools a year. Because it's a 10-week program, there's a minor commitment where the families would typically agree to come to the program. They get family meals. During COVID, when we weren't able to meet in person, they were still facilitating the program in a virtual space, even by free phone conference calls and things like that, and providing like grocery gift cards to try to keep families engaged and things like that. So a program like that, which has shown some promise and some effective and positive feedback from participants, maybe that's something we could look at trying to expand and reach more schools on an annual basis versus the 4 that we're only able to reach. So that may be, viewed as a capacity issue. As far as like our adolescent substance use prevention program, we utilize an evidence-based curriculum, the Botvin Life Skills curriculum for high school students. We are hoping to eventually get to a place of facilitating that into the middle school level as well, because there is an evidence-based middle school curriculum as well, and we know that a best practice in prevention is providing education and awareness early and often. So looking at that, but right now we only have 1 staff person that's able to facilitate that, and we're working in partnership with MCPS where they're identifying schools who are interested in the curriculum, and we're working with them and setting up resource tables at like the school lunches, and youth are actually self-referring and say, hey, I want to be a part of this group, and we're having 30 and 35 to 40 students that are signing up. And then one school recently just wanted to do a continuation of the education curriculum because the students enjoyed it so much. And these students self-referred. So we know that they need some kind of support, something beyond just, what the immediate things that they're getting. But, that as well is a capacity issue, because we would probably want to reach all 26 high schools and all of the middle schools with that type of curriculum, so that it's a funnel process. In addition to that, we have the Youth Ambassadors Program, which we had about 34 students sign up for it this year. We have probably about 11 that are actively engaged, that we're, providing leadership training. We're providing a lot of, education and skills so that they actually can take that information back to their peers and educate their peers about the dangers of substances, about, different things about coping and things like that. So we would like to have students from all of the schools, and start a pipeline from the middle school level all the way to the high school level, because I think, when looking at prevention and looking at the landscape of substances now, it's a social norm kind of thing. It's almost like at one point, kids were accessing these prescription medications from the medicine cabinets, but it actually has shifted and changed a little bit where they're accessing it from social media, and on the black market and things like that. So making sure that they understand those dangers and things like that, making sure the parents are aware of that as well. We've talked about increasing or trying to align ourselves with, like, child welfare services, child protective services, and see what kind of parenting programs they have, so that we can look at educating the entire family and not just look at that one individual, because you want to increase those protective factors, which is a best practice in prevention, to try to reduce those risk factors. You have that one strong protective factor that could mitigate an array of risk factors, and that's what we're really trying to do in prevention.
So you mentioned 4 programs. Are there only 4 programs across HHS targeted towards prevention and raising awareness?
So we do a lot of community awareness campaigns as well. So we have, campaigns working with the community partners on the dangers of the non-medical use of prescription drugs, the dangers of underage drinking. In addition to, we have a fentanyl risk reduction campaign, which is around that, educating around the dangers of fentanyl, the importance of, if you make that decision to go slow and not maybe use as much as you normally would, to hopefully prevent that overdose. In addition to, what was shared about the Adolescent Clubhouse program, we do a lot of partnering with them, as well as, a lot of, different community agencies that, serve youth throughout the county that we partner with and work with and try to bring programs and things to.
Thank you for that. I want to get a clear understanding. If I want to go on HHS's website right now and I Google, opioid prevention, how many programs would I come across that are actually, being used or in operation? How many programs, how many campaigns, and how are we evaluating them? Because there's a lot of good things that you're saying, but how are we evaluating them? How are we deploying them? And how are we deploying our staff to ensure that these are being used effectively to address the issues that we're trying to address?
So in prevention, we utilize a lot of data. So everything that we do is data driven, right?
So we don't have one repository for all this information.
So Ben, let me respond. Good morning, Councilmember Sales. One of the reasons why we decided to consolidate our efforts in HHS, just to address those questions that you just asked, to determine how many programs we actually have, to look at the evaluation of the effectiveness of those programs. I can't give you a definitive answer this morning because we are assessing where those programs are. For example, under our children, youth, and families, we have the positive youth development, our PYD. If we get those involved, that's yet another program, but looking at the effectiveness of those programs and the impact that our programs across HHS are having in the community has yet to be determined. We really need to do an assessment of that. We need to look at those assessments to identify the best practice or better practices, and then how we can publicize those, so at the community level or at the state level. So we haven't gotten there yet. We have many programs, but we haven't consolidated them to specifically look at this issue, if I understand your question.
No, that's my specific question. So I'm just wondering what support is needed or what efforts are being made to consolidate and streamline the program so that we can better test their effectiveness. Because if we're just throwing things out there, we're not going to see a decrease in the numbers. We're not going to see an improvement in people accessing these resources or, dealing with this overdose problem if we're not targeting the people and the problems that we need to. So,
Thank you. Very good point, Councilmember Sales, and thank you all for your responses. Councilmember Mink, and then we're going to move to the next panel.
Thank you all so much for being here today. Do we have data on the circumstances around the various overdoses? Things like, are youth mostly overdosing after intentional use of fentanyl or through laced other drugs? Who are they typically around when they overdose? Are they in schools? Are they outside schools with other youth? Are they in their households? Things of that nature. And of course, I'm asking so that we can think about how that can help us to direct our energies towards different types of programs and outreach efforts.
So we do have the overdose fatality review team, which looks at cases on a monthly basis as far as overdoses, trying to, and that group is inclusive of, DJS and other partners, law enforcement, treatment programs and things like that. And so what they do is they try to look at the case from a holistic perspective, looking at where the person might have accessed treatment, where the person might have had involvement with law enforcement or Department of Corrections and things like that, and try to figure out if there were where the gaps are that we may have been able to engage that person to prevent or mitigate that overdose or something like that. And so I know that group meets on a monthly basis, trying to explore cases. I'm not privy to if they've had cases of individuals under the age of 18 as of yet, but I do know that they receive cases from the Office of the Chief Medical Examiner's Office to explore on a monthly basis, and they usually review about 3 cases each month.
Thank you. It'd be great to get our hands on also whatever of that data is available. And do we have, sorry, to clarify, is part of that collecting data on what those youth overdoses look like, where they are, what they're accessing? Do we have that data?
I believe the information on what they're overdosing may come from MCPD. So that data, I'm pretty sure they capture that data. And then I know we also get a copy of a toxicology report from the OCME's office as well, which could let us know what was in the substance that potentially caused the overdose.
Okay, thank you. Let's see, what are the options for parents whose kids don't agree to treatment? Because we are hearing from a lot of parents who are in that circumstances.
I would recommend for parents to get connected to some of these parent support groups. There is a concern about, when a parent identifies that their child is using substances and their child is not willing to go into treatment. All treatment providers at this point in time do require kids' consent in order to participate in treatment. There are several different options for parents to connect with other family members who have kind of been there, done that, and have walked through their own child experiencing substance use and or mental health concerns. So there's peer support family navigators, as well as the parent support groups, where they can hear information from clinicians about how to support their child, how to set boundaries, how to encourage them to participate in treatment. In addition, the state has provided a resource called the Parent Craft, which is typically a $200 program, but it's available for free for any Maryland caretaker. So it is a series of videos which provides information for parents about how to talk effectively to their child, how to communicate effectively. It's all based off of cognitive behavioral therapy strategies and techniques. And this is an evidence-informed approach to helping parents connect their child to treatment. They've found that there's a 71% success rate in having parents connect their children to treatment.
Thank you. You said that was called Parent Craft, C-R-A-F-T?
Correct. Yes.
Okay. Do you know if that is available in other languages besides English?
I've requested that from the state, and they have responded that they hear me and that they are working towards that. So
okay, so currently only available in English,
correct.
And perhaps some additional requests from us would be helpful there.
Yes.
Okay, great. The parent support groups, are those available in other languages?
As far as I know, there is English-speaking parent support groups. I will have to get back to you about if it's available in Spanish. There may be. I know that one of the providers who offers these support groups does have Spanish-speaking clinicians on staff.
Okay. Yeah, that would be great to know. Thank you.
Yes.
And while we're on the topic, if we could get a breakdown of which of our programs are bilingual or multilingual, including which of them have, a breakout session that is available, or a scheduled session that is available completely in that language with all the materials in that language, and which ones have, translation services, interpretation services that are available. It seems like it would be important to do whatever I can to expand, whatever we can to expand accessibility, including making sure that we have Spanish-speaking Narcan trainers at these very in-demand Narcan trainings. I think would make a big difference. Can I do one more?
Yes, you
okay,
can.
thanks.
Yes.
Thank you. I'll be quick. All right, just thinking about how to get these resources and information into the hands of our youth directly. The BHCS program that provides the free drug testing, can a student or other person bring illicit drugs and have it tested without fear of repercussions? And also the fentanyl test strips themselves, which are being distributed through community partners, which I think is fantastic. But are we getting those directly to students?
I would probably say that we might be getting them to students indirectly, because a lot of times I've known of students who access the Narcan kits from Fire and Rescue, because those situations are without question, like there's like not an interrogation type situation. You just go ask for a Narcan kit and then you get fentanyl test strips that way. We've tried to really educate young people around the fact that even if you test your pill to see if it has fentanyl in it, it may test negative. And that's because, the fentanyl may not be evenly distributed within that pill. And so there's a chance that they could still experience an overdose. If we've had kids that have asked for fentanyl test strips at different community events, and we have given them to them just because they've requested them. But usually we haven't just like marketed it, because we're actually just trying to prevent them from actually going down the path of even using. But they are available. Yeah.
Thank you. Yeah, it seems like that might be. Sorry, go ahead.
And then to your second point, we are in the process of working with the state to get the harm reduction team trained up to accept like residue, like a baggie or something like that might have had a substance in it, to send it off to a lab to get it tested to see what it is. Just trying to get a better handle on what's in the drug supply beyond what we learn from like law enforcement.
Thank you. Yeah, I mean, it might be helpful to think more about that, because if we think about, like, I'm hearing like a comparison that could potentially be made between like abstinence-only education, where it's like, your best means of avoiding this is just not to do it at all. But realistically, abstinence-only education has only resulted in more pregnancies. So if there was, if we were able to do targeted outreach to youth that also provided them with the information that this is not a foolproof system, I wonder if that would be helpful. Thank you.
Yeah, called Abstinence Plus, and it has been evaluated to be much better. Councilmember Alvarez has one final point.
Thanks.
Question.
Just very quick. Two things. One, just to reiterate the importance of the Restoration Center, which I know has got state fundings ready to roll. We're just trying to work out where exactly that's going to go, but we needed that yesterday because it directly connects to the conversation that we're having right now and could help prevent some of these tragic instances from happening in the first place. And Mr. Stevenson, I really appreciated Councilmember Wink's question. I was going to ask something similar. What you're describing sounds a lot like what we had back in the day called the Gang Intervention Partnership. After each gang-involved incident or homicide, there was a group of stakeholders who were on the ground. I used to be one of those people that looked at what happened and then looked at making sure there were resources provided for siblings or other gang members, preventing them from, continuing and escalating the conflict that had arisen or the tragedy that had occurred. I would, as Councilmember Rink noted, love to follow up. Data is absolutely important, but just a report or just a series of recommendations. That group is key and has a unique perch and perspective that most other agencies don't have, certainly not on their own. And I'd love to follow up, and maybe we can. I don't know if we need a joint session, but to meet with that group of individuals to hear directly from them. I think that would be very enlightening and helpful. Thank you.
It's a good point, and I think I heard you say on that group that you're not sure if they've even taken up youth cases.
Yeah, I'm not totally sure, just because I know there's a child fatality review team as well, and so that group might be the one that is reviewing cases of individuals
Let's-
under the age of 18.
Let's find that out.
Yeah,
Whoever it
yeah.
is, we want to talk. I think there's some follow-up to do
I
there.
can answer that.
Okay, great.
As a member of the Child Fatality Review Board. So when a child passes away or dies in Montgomery County for any reason, it goes to the Child Fatality Review Board, which meets quarterly. So whether it's suicide or car accidents or whatever it is, we have a full discussion. The Montgomery County Police are involved, child welfare, a lot of different agencies are involved in that. And so we do discuss that. We had we do discuss when a child overdoses, student overdoses, and what the cause of that was, why it happened, did the parents know about it, what was in the police report. Those things are all discussed, and then recommendations are made by the Child Fatality Review Board back to whoever needs to address whatever issue it is. And so that has happened. We just had one review a couple weeks ago where there was one youth who passed away from an overdose. I expect that there's going to be a couple more in the next one in April, just because of knowing that who has died in our community. So so that does happen, and recommendations do come out of that.
I appreciate that, and I think having obviously specific to the individual, respecting privacy, but any policy implications that and recommendations come from that, we want to know. So I think you could, as a follow-up, look at those. We've had, for example, we've had 5 youth overdoses this year.
Right.
Once you review those, I think we need to move urgently to see are there any trends, parts of what do we need to learn, what are there things we can do. I think that you're hearing that from colleagues. And then just to put a point on Councilmember Sales before we move to the next panel, to staff, I do think having just a analysis from HHS of the programs we have, just putting that all in one place and sending that to all of us, to the entire council, of what's available, how to access it, as you're working to fix the website and do all that stuff. But even before that, giving us that list, I think, will be very helpful.
If I can just add one comment about that, because I know I've heard everyone say data. As we've kind of come together in HHS and done a deep dive of the programs that we have, whether it's children, youth and families, public health, behavioral health, it's become clear that data is everywhere, but it's not consolidated, and it's not current. And so public health may have data, the police department has data, MCPS has data, the state has data, and the state is really the repository for all of that data, but it's a year and a half behind because they want to deduplicate it. They want to make sure that the hospital's data is matching what the police data or fire and rescue data is. And so we're now looking at a way to kind of consolidate with that within Montgomery County to provide better local data, because we can't wait. It doesn't make sense for us to wait a year and a half for the state to publish their data, for it to be accurate for us and to understand it. Because without that data, we can't tell you whether the programs are working. If a year and a half from now we see that, oh, well, that didn't work, we can't pivot. And so we are working as a group now that Dr. Bridgers mentioned, to come up with a way of getting that data that's available more locally, and be able to use that to answer your questions about whether a program is successful or not.
Appreciate that. Obviously, yeah, it's not useful if we don't have it in real time and we don't have it complete, so thank you. Appreciate this panel. Please you can move from your seats, but don't leave from the room, because we're going to come back to you if we have time. Would love to welcome up MCPS and Montgomery County Goes Purple, Dr. Patricia Kapunian, the school system medical officer, Peggy Pugh, Brian Hall, the chief operating officer, and Laura Mitchell from Montgomery Goes Purple. If you all could transition up. And thank you to our Chief Jones and Police Department for hanging with us. All right. Thank you, Dr. Cooney. It's good to see you. I've seen you on the big screen. Haven't seen you in person, so thanks. Glad to have you here. Are you going to lead off, or is Brian, who's going to start from MCPS? You're going to start. Okay. So just go ahead and hit your mic there. And I'm told your presentation is only about 7 slides.
Trying to keep it brief so we have plenty of time for questions. Sorry.
You're reading my mind. Thank you.
And actually, if you can go to the next slide, thank you so much for convening this opportunity to talk to the joint committees. I really think it demonstrates how integrated and comprehensive this response to this epidemic, this crisis, has to be. You know, children are members of families, I say that all the time, and they're members of communities, and they don't necessarily experience life or the community from one agency, one organization. They're not just students. They're people who go home, have siblings, move through like the world. So they may not always know that this is a police thing, this is a health and human services thing, this is something that happens only in schools. So having these kind of conversations has been incredibly useful, and it's been wonderful to be able to work so closely with the HHS and our police partners on an integrated strategy, and to be able to talk now to county leaders in a coordinated way. I just think is so wonderful, and I'm thankful for this opportunity, because I think we can make great strides doing it together, all together now, as you say. I think Mr. Hodge set me up talking about data, because this is something our community has been asking for. They want to know what's going on, how important is this, and no matter how much we say this is a crisis, this is important, without knowing the data, it's hard to know, are we making progress, you know, what is happening in our communities, and how do we know when it's getting better. The snapshot of what happens in schools, I think, you know, from the data, excellent data that Dr. Davis shared on the national level through YRBS, and what's happening in the county, shows you that overdoses are happening outside the school wall. So this is not just a problem for the schools, though as the school system, we're trying to be very thoughtful about both our role and unique opportunities in being a community partner for this crisis. You know, fewer than a quarter of overdoses that were reported to emergency rooms, fewer than a quarter of that number were suspected overdoses to which we responded with Narcan in the schools. We've done that 12 times this school year. Dr. Davis described 57 that appeared in emergency rooms. And so you already see how there's a disconnection between how we describe this problem. The problem is with Montgomery County youth, not just students. So there have been overdoses in students who are Montgomery County youth who are not in the public schools. So it's really critically important that we describe this together, and that these efforts about data and how we can get data on a local level quickly to our community are incredibly important, but also to educate the community. And, you know, where is this data? What does it mean when we talk about police data? Who comes, who responds, fire and rescue, to a residential call? What shows up in the ER? What's happening in schools? All of those are parts of a larger picture, and we need to understand what the larger picture is. We also need to understand that when something happens in a school, it's our foremost priority to prevent any harm to that student or to that family. So, I mean, we're fortunate that it doesn't happen very often that we have to administer Narcan, or that we lose a student to an opioid overdose. But when it happens, people tend to know who in the community something has happened to, so it's very difficult for us to share any details that are being demanded by the community without violating the privacy confidentiality of a family who's struggling in a very difficult space. So we do our best to raise awareness, to provide resources, to understand the scope of impact of an individual incident, and also express as a community everything that we're trying to do with our partners to combat this epidemic. But first and foremost, individual student safety and preventing harm is something that's very much on our minds. So next slide, please. So here are some of the sort of missions around the partnerships that you asked us about. Coordinating district-wide health promotion about the dangers of illicit fentanyl and resources for prevention and support, as well as working on community levels. So these efforts not only have to be integrated across the community, but multi-layered, depending on what the scope of the work is for that particular level. So we do try to be mindful of what we are doing through broad outreach at a district level, like a forum, where we're trying to maximize participation and reach, and then also work at the individual community level, cluster level, school level, work with individual families, and how we bring that to students. So all of this health promotion, education, and intervention, as you mentioned, Councilmember Albornoz, has to happen on all these levels simultaneously. At the same time, we never lose our mission as a school to provide education and a safe space for our students. So schools have a particular role in terms of safety and education, but we also have a unique opportunity as the face sometimes of the entire community to parents and youth to be able to use our spaces and our voice to connect to resources that exist and are offered by experts outside of the school system. So we have that dual mission. We do it at many layers, and we think about what happens inside our school community and what we can do to connect our community to all the great work and resources that are available to them, that you make available to them in the wider community. Next slide. So here are just some examples that don't represent all of the community collaborations, but we try as much as possible to work under the Community Coalition of Montgomery Goes Purple. This is a group that includes many county agencies as well as community organizations and individual people who work and are dedicated to the space of substance use prevention and response. And it allows us to think about the problems on this like greater community based integrated scale. So Montgomery Goes Purple has sponsored the events. We've gone to, has sponsored events in the schools. We've participated as partners in events that they've sponsored out in the community. And we try to make sure that when we're addressing this problem, which is a community problem, that we're looking at it through a community lens as a partner with not just our critical relationships with public safety and public health, but with other folks in Montgomery Goes Purple. And here you've heard already about some of the more specific partnerships that we've embarked on with the HHS, who is the most important partner in providing school health services within our schools, but have also helped us. We've worked a lot with prevention and harm reduction services with Mr. Stevenson to bring youth outreach, not just through the substance use prevention groups, but also through outreach. So coming and talking at town halls with students, assemblies, those type of ways that we can bring clinical experts into schools is something that we would really like to grow. And then, as he mentioned, we have the substance use prevention groups that have been very popular, and we have our first school now going on to their second iteration of this 4-week program. We've had for years the Recovery and Academic Program at the Landing, where kids in recovery can also have access to curriculum and treatment simultaneously. Next slide. Here are some of the things that we do sort of inside the school system in terms of health education. New standards this year have expanded education with regards to medical uses of opioids, the effects and risks of opioids and fentanyl specifically. And we go above and beyond to now think about how we're going to introduce more specific overdose prevention skills, including Narcan. I do want to remind you that health class is not the only way that we provide education to our students as well as our parents. So in our formal health curriculum, there is information sent to parents about how to engage with it, but we also rely on our curriculum experts as well as our clinical experts in the community to help us put together materials so we can provide health education in a timely way outside and in addition to our formal curriculum. We've been doing a lot of work that I'm sure you've heard of. We've had another community message go out from Mr. Hall's excellent team just last Friday about the very specific and focused work we're doing in safety and securities. We've heard loud and clear a lot of the suggestions about, or concerns and suggestions about bathroom security, for example, and we have laid out in these community messages and to our communities the specific plans for further engagement and safety that are currently underway. Next slide. And here are some examples of the different levels of community engagement. So the district-wide events like the Family Forum, we are targeting for broad outreach. Our first one was Up County, last Saturday was Down County, our third one will be East County, and those are 2-hour events where we are really trying to widely broadcast this is what fentanyl is. Here are the resources and the people in your community who are working on it. We've had extraordinary voice data at both forums, sort of letting us know more about what specific communities need, and that data at that broader level can inform the more specific efforts at the community level, the school level, with students, and even individual families and people have come forward asking for help, and we've had the opportunity to connect them with resources at those forums. But again, those forums are broad district events and they're not the only effort. We have other community-wide, broad-ranging efforts for prevention and response, and then different ways that we're thinking about and working on outreach to parent and caregivers as well as students. We've had amazing engagement from youth leaders as well as parent communities. And one thing that has really changed since we have been going on this escapade of awareness at the beginning of the year is people are coming to us asking for action, wanting to be involved in action, wanting resources. And that's a very different conversation we've been having in the past month than what it looked like 4 months ago when people were literally asking, why are you talking about this? Why is this important? Now this is our experience and this is what we need to do together. So it's been great to have those voices come up to the table, especially with students. I mean, we talked with the HHS very recently about the Youth Ambassadors Program and what an extraordinary opportunity that is to change norms. There's lots of evidence for peer-to-peer support in terms of how to get kids engaged and come forward and want to be in treatment. So the youth piece is incredibly important and something that is really, really growing. Next slide. And then if you have questions about Narcan and Narcan in schools, we've covered that already, but it has been in every MCPS schools, including elementary schools, since the 2018-19 school year, and that was related to state law that was passed in 2017. All staff are required to complete an awareness course, and then health room staff and designated staff in MCPS are required to do the hands-on training. What's different this year, we have expanded the number of doses of Narcan available at the secondary school level, middle schools and high schools this school year, and are also expanding, doing more thinking about where those doses have to be, who else needs to be trained, where are the other spaces that students are after school, in athletics, just in terms of what the reach of that needs to be. And we've been very thankful to have prevention and harm reduction services help us in that effort. With regards to students carrying Narcan, this is something that our youth community is very interested in. We have made it available to them through our forum and connecting them through opportunities to get it through the community. But I appreciated your point about harm reduction. When you do harm reduction in youth, it needs to be very intentional about, addressing their concerns about the Good Samaritan law. What happens? Will I get in trouble? How do I use this responsibly? If I crush the pill up, because you have to crunch it up, suspend it, do the chest strips, can I use it after? So there are all these questions, and when you enter that space with youth, it has to be very intentional. It's something that we're very interested in, and obviously we're making it available to youth, but the next steps of how do we do harm reduction effectively, responsibly in youth, that's where the conversation is now. Next slide. I think that's it. Thank you very much again for this opportunity.
Appreciate it. Thank you. And we will stick to the 5 minutes so that we can maybe do another round at the end and ask you all to stick around as well. And that last point is just so important, the harm reduction work. We have to be transparent. We have to be open with the students. These forums have been great. I spoke with a group of students at Northwood last month, or earlier this month. I think everything pushes together. But several pulled me aside and said, yeah, I know people that are doing this, and I just really don't, I don't do it, but I don't really know if I should say anything, and I feel weird about it. All the things you just talked about, and it's so critical that we are giving them the tools to break down those barriers and to the information, but also the literal tools like you're discussing, so that, they can help refer their friends to services or themselves, or test what is being used, realizing that, the ultimate goal here is to stop the substance of any use of these pills, but in the reality, we want to save lives, right? So really appreciate you saying that. 2 quick questions. The strategic plan that you, I think, have alluded to, that's a part of these forums, working with Montgomery Goes Purple, is it down somewhere? If I want to look at the colleagues, myself, we want to look at it, the community, want to say, okay, what's our response from the MCPS point of view? And obviously we need this for the county, that's why we're here today, about what you're doing, what's available, and that where can we, is that available right now?
That's not something that's available. One thing is that this has very much been happening very quickly, and we learn so much at every forum about what the community's needs are. But in terms of the structure and framework, working with our DHHS and police partners, I think that's that's definitely something we can do in terms of what are the different avenues of response and what are the different layers. It's something that we have internally iterated, but I think what would be great, and I think maybe what you're asking for, is what does that look like on the county and community level?
I think we absolutely need it. I mean, there's a void created that gets filled with a lot when you don't know what's happening or you feel like there's not a plan. We are doing a lot, and that's one of the points today, but we need to communicate that effectively. And it's always a challenge, inappropriately and competently in multiple languages and, in communities that need it. So I think I do think that needs to be a stated goal, and we need to be working towards that so that we can have that, and then also as part of that, how you're doing this, how you're getting to every school, right, or what your priority is, right? You've done 2 high school forums, right? I know that's not all you're doing, but if I'm a parent, and I am, of MCPS students, and I'm thinking, okay, well, what's going on in my 210s? What's happening at our level, and how that's being communicated to parents? Do you understand what I'm saying?
Yes.
Okay.
I mean, if the question is how do I find out what's going on in my individual
Correct.
school,
Yeah.
and the first question was how do you reach every single school? So when you look at it as a layered response in terms of what we're doing at the district level, what we're doing at the school level conversation is very similar to how do kids know about behavioral health resources, wellness resources, and so that conversation about the mental health infrastructure in schools that connects them to CAS, that connects them to mental health services when they need it. That is the mechanism by which kids find out what's available from their school community, because honestly, it may look different. As we meet with, my team meets with individual schools, we're learning so much about how different the needs can be and what the priorities are for particular communities are different, how you roll out the services. So what is available at individual schools will be available at the school level.
Is the principal, who's the best contact? If I'm the parent and I have a concern, where do I go?
So we work with the principals to determine what their needs are, but we have the website that shows through Be Well 365 who the different resources are in your school, your social worker, your school psychologist. We just piloted the Stronger Student app, so that's something that's new, but can also be used to understand what services are available in the district and at your school.
Obviously no wrong door. If I go to the principal, I'll be referred to wherever I need to be, right? Okay. Thank you. I will pause there and turn to my co-chairs, Councilmember Alvarez.
Thanks. So I want to pick up where Chair Jawando just left off. So first, I appreciate MCPS acknowledging that this is a problem. This is a crisis. We're not burying our heads in the sand. We're leaning into this. The 2 community forums, I had the opportunity to attend the one on Saturday, I think demonstrate to the public the urgency that MCPS is showing. That's great. And I know that we're trying to establish policies and protocols from the central office and then extend those to the individual schools. But I also know, having been around a long time, that the administration of how that actually translates into programs on the ground varies greatly depending on the administration of each individual school. How are we encouraging and supporting administrators who are overwhelmed on a good day dealing with all of the various issues that they have to address in addition to the crisis that we are talking about right now? What specifically are we doing to ensure consistency in the delivery of those programs and services at the school level?
Thank you, and thank you for recognizing our extraordinary administrators and how much is really on their plates right now. And that's one reason those conversations have to be individual. We've also spoken at to the professional learning communities, to the middle school principals and the high school principals as a group, to kind of understand what they're seeing on the ground and to lay out what types of resources and programs might be available through the county. Because let's not forget that most of these specific clinical services are not offered through programs in the schools. The schools connect to clinical resources and experts that exist outside of the school walls, and we can bring experts into the schools. So the programming support might happen outside, and in the schools we're talking about screening, referral, connectedness, and then supporting the clinical response. So we have had conversations with the principals as a group, and then also meet with them individually to see what the concerns, needs are for their communities and what the response needs to look like.
So similar to the question for HHS, the follow-up will be asking for the repository of that information from MCPS, and how are we tracking that? What are the administrators saying? And there needs to be a heck of a lot more done to ensure parent engagement here that is culturally humble. And I know that's a challenge. It always, again, on a good day. But there have been thousands of families that have participated in just the 2 forums that you all have set up, which demonstrates to me parents are scared and they are terrified. And the parents that came and spoke to me at those events, as Councilmember Fanny Gonzalez noted, said the same things to me. They also have deep concerns with safety and security issues. The protocol was pretty straightforward when we had our school resource officers, where to go, who to talk to if somebody did try to sell their child drugs. That is no longer clear. And the fact that we can't get the bathroom issue under control is indicative of a much larger systemic problem. And we have engaged with the community engagement officer model, which people are still confused about. And we've transitioned in a way that's been awkward at best. And some of these questions will carry over into our police department, but there has to be clear and concise ways for families to report incidences that are occurring within their own schools. And for those students that are in crisis, and when we talk about substances, we're talking about opioids, but this extends to alcohol as well, and a variety of other substances, including marijuana, which have become, sort of a problem on a number of different levels. And our kids are crying out for help. And so this is more of a comment than a question, because we're going to have to follow up to get some of the responses. But we do have to acknowledge that we've identified a problem. We are pouring in resources, but we have to track the effectiveness of what it is that we're doing and see if we need to double down or even triple down in certain areas. So with that, I yield back to you.
And if I could add too, I appreciate that, and from a security perspective, or let me just say, from a whole school's perspective, this is something that, as a lifelong educator myself, and I speak for all of my colleagues, that we are very concerned about and we take very seriously. I have 2 young children.
Just identify yourself for the record.
Oh, sure. I'm Brian Hall, I'm the Chief Operating Officer for MCPS. And I have 2 young boys in the system as well who are coming up and are going to be dealing with this. And so it's both professional and a personal challenge for myself and many of my colleagues. I would, applaud the work that Dr. Kapunin has done, that Laura Mitchell has done in really getting ahead of this and really bringing this to the forefront of our community conversations, but specifically around the security piece. We have worked very closely with our principals. We have talked to our students. We have talked to our families and our communities to really gather the input that they can provide to us, because it's twofold. It's one is addressing the immediate security concerns, and you mentioned the bathrooms, but it's also getting to the root cause of what is leading to this type of behavior. And I know the previous panel mentioned mental health, which is something that I think we're all realizing coming out of the pandemic is a much larger, widespread issue than maybe we had realized prior. So we met with the principals just on Friday. We followed that up with a detailed community message out to our entire community and our families on Friday afternoon about what we're doing to address the specific security concerns in the immediate time. And so that's adding additional personnel to our schools to make sure that they have the people power that they need to monitor the bathrooms. We've also updated our standard operating procedures for our security personnel to strengthen some of the language in there and really make it more specific to the current situations. The last time that had been revised was over a year ago, before the fentanyl issue became such a front burner issue that it is today. And so we're making sure that all of our security and our school staff are monitoring all of the bathrooms throughout the day, physically going into the bathrooms and monitoring what's going on in there. We are making sure that all of the exterior bathroom doors are propped open with latches or magnetic locks, so that they aren't able to go into the bathroom and just close the door. And then, of course, if a school personnel walks by and sees that the bathroom door is closed, that would raise an alarm that we need to look into this. I guess that those are the main things that we're doing to address the immediate concern, and then we've got a whole host of things, including reviewing the student code of conduct and developing a student advisory group around safety and well-being for our students that are medium-term and more long-term issues that again, hopefully will help us get to the root cause of what is leading to some of this behavior.
Thank you. And I believe we're having a joint session to talk about school security between public safety and education and culture in the near future. So there'll be a lot of follow-up at that point, but I appreciate that. Thank you.
Thank you. Councilmember Katz.
Thank you very much, Mr. Chair. And I want to associate myself with what my colleagues have already said, and I'm going to try not to repeat that. But this is a crisis, but this is not a new crisis. Dr. Kapunen, I have to tell you, Montgomery County Public Schools is very fortunate to have you, as is HHS, is to have Dr. Davis and Dr. Bridgers and all your entire team. And let me say very publicly, I appreciate Montgomery Goes Purple. When former Salisbury Councilmember Mitchell moved to Rockville, Salisbury's loss was their gain, and I knew her when she was working in Salisbury, and I'm very proud to know her now. Years ago, Gaithersburg, when I was before I was mayor, when I was on the city council there, we brought to every school in Gaithersburg, not to everyone in Montgomery County, but every school in Gaithersburg, a program that talked about drugs. And we gave each student, Gaithersburg is a little smaller then, but we gave each student a T-shirt. We had programs that came into the school. We had corporate involvement. It really cost the city next to nothing, because we had a lot of corporate donations, and they came in not only with money but with people to help us get our message out. And we had it a different way to get the message out to various grade levels. Obviously a high school has a different way to discuss things with them than you would in elementary school, etc. And we did believe, and we do believe, that it made a difference. Of course, it was a very, very different age at that point, but my point on this whole thing is that I think we need to work together to make certain that our programs are getting a message to not only our students, but to our parents. What we did in that case is we had assemblies in each school, but then in the evenings, a couple times, we had meetings for parents so they could see what their students were doing. We invited the parents in if they would like to come in during the day to see the program, but not obviously, especially even then, parents didn't take the time to do it, or couldn't take the time, they were working, and we certainly have more of that today. But I think bottom line on this, and I know we're going to be short on time, so I'm going to wrap this up, but I think bottom line on this is we cannot afford not to give the resources necessary to have this, to help correct. We're never going to solve this 100%, but we certainly can work together to solve much more than what we're doing. And I believe we need to have a larger, in the words of Ike Leggett, that larger table where we all sit around, figure out with our parents and our students and everyone else, figure out what's the best way to communicate this message so that it's understandable to each. For someone to believe, and we've heard it a couple of times today, for someone to believe that they could be hurting their friend by telling the truth that they're having an issue, they're not hurting their friend, they're helping their friend, but they have to understand that. And so I think we all need to continue to work together. But thank you all very much for what you're doing. Thank you, Mr. Chair.
Thank you, Chair Katz. I want to turn next to Councilmember Lukey.
Thank you. Just one comment and observation about the forums, but those are forums where the participants are self-selecting and they're already engaged and interested, otherwise they wouldn't be coming to the forum. But this is an age-old problem where we have difficulty connecting the people who need to hear the message the most, who maybe aren't even aware they need to hear it, to the things and services that we have available. And so it's the folks who aren't coming to those things and the kids who don't show up for those programs that we need to really find a way to connect with. With respect to the safety and security email that went out on Friday, and concerns that the kids have related to what's going on in the schools, right? So I've heard, I have 4 kids in the schools, but I hear it from a lot of other teenagers in particular, the upsetness over the bathroom issue, right? They don't feel safe. They can't use the bathroom. The bathrooms are locked. Kids are doing things like vaping THC in vape cartridges in the bathrooms. In one school system, it was not MoCo, they were trying to film kids using the toilet in bathrooms where they'd taken the doors off the stalls as a security measure. Now, I know you didn't do that here. But there's a lot of frustration amongst the children about, hey, I get it, people are doing drugs and I don't want to be a part of that, but I do need to use the bathroom. So I do appreciate that an effort is going to be made to make sure that that is feasible for everyone. But beyond fentanyl and the THC and the cartridges, Benadryl is now a popular over-the-counter substance that kids are using to get high. And we just had a news article that came out at the end of the week where SRO in Charles County is investigating where a child overdosed on Benadryl at their school. And I'm aware of a case here in Maryland where that occurred not on school grounds. But what's being done, you mentioned revising the disciplinary code, what's being done to really make sure that enforcement is happening for the disciplinary code in the school? Because if you ask teenagers how it's been since they came back after the pandemic and went back to full-time learning, they'll say, yeah, that says that in the book, but they don't do anything about it. And there's so much of that, yeah, they don't do anything about it going on, that I think that's why we've got a lot of problems that have blown up out of proportion.
I appreciate that question. And it goes to a question that was raised earlier as well, as far as how are we making sure that the code of conduct and the standard operating procedures are being applied with fidelity across all 200 and now 11 of our schools. And that is a challenge when you've got a system this large. And so I think that there are, multiple ways that we're addressing that. One certainly is through communication with our principals and hearing both what they're experiencing, but then also what the expectation of the school district is. And then also with our youth and with our students, and really, again, trying to get to the root cause of what is causing this. Because, let's be honest, kids getting into mischief in bathrooms is not anything new, but the types of the drugs and the types of the experiences that they're having in the bathroom today are. And it's unacceptable, and it's something, that while we address the security challenges, we also want to make sure that all of the students, most of whom are not contributing to this behavior, feel comfortable and safe in the bathrooms. And so I'll ask Mr. Edmonton to speak a little bit more around how we're addressing specific behavior challenges. But I just wanted to also address the issue of closed bathroom doors, because we've heard a lot about that, and I'm not sure that everything that is out there is completely accurate. So one of the things that we did, as I mentioned, was meet with our principals to try to figure out what is working in some places. And one of the things that some of our schools have had success with is, in our large high schools, not every part of the building is being utilized at all times. And so if there is a certain wing of a school that is not being used for a certain part of the day, that wing could be closed down either with a security fence blocking off the whole wing, or sometimes locking the bathrooms in these areas that are not being used. And so that is where the locking of the bathrooms would be coming into play. But we certainly want to make sure that our students have access to clean and safe bathrooms around and in where they're learning and doing school during the day.
Hi,
My name is Greg Edmondson, Director of Student Welfare and Compliance. Good to see you all. And we talked a little bit about this with the Student Code of Conduct last week when we met, talking about our hate bias incidents. So we do have a team right now that is looking at our Student Code of Conduct to make sure that we have the language that is necessary within the Code of Conduct to be able to, aside from restorative justice and making sure that kids are coming together and repairing and getting well again, but there are disciplinary measures that need to be taken. And so we're working very closely with our school administration so that there is a very clear linear alignment with our memorandum of understanding with our police, so that anything that involves drugs, anything that involves weapons, gangs, type of things, that we have certain steps we have to follow, and the police are involved in that instantaneously. But then also, what would be a consequence? What would be the level of that consequence within the Code of Conduct? So we have level 1 infractions all the way up to level 5. Level 1, 2, and 3s, they're not suspendable. They are things that we'll take care of within the school. There might be, detention. There might be different things that are still in place within the school. And then you have the level 4 and 5s that go from suspension for 1 to 3 days, but also possibly expulsion. And so we're looking to make sure that all of these things are aligned, because we want to make sure every one of our school administrators is aware. And thank you for referencing our school principals, because they do a great job, but there are so many things coming at them right now, especially in the last 4 months. Making sure that the MOU is, that they understand the MOU and what is entailed, making sure they understand the Code of Conduct, as well as the changes that are coming to that Code of Conduct through that stakeholder group.
And is it possible to, and you may do this or this may already be happening, but to, as a part of the school disciplinary measure when something is happening on school grounds, to do a referral to treatment, right? So in Dorchester County, for example, they had a pilot program that was grant funded where if students were caught vaping in the bathroom, they had a choice, so you could take the school disciplinary consequence, or you could go to a cessation program with your parent.
So we do work closely with Student Family Engagement Office as well as our Student Wellbeing team. So we all collaborate very quickly, but also very clearly about, okay, what's the best circumstance or what's the best next steps for this particular case. So again, it's not you did this happens, this happens. It's we do take all cases, as an individual case, but we do have these guidelines to follow and these policies to follow.
Okay, but would a type of intervention program like
Could
that be something that you could use within your toolkit? Yep.
Absolutely.
Okay, thank you.
Thank you, Councilmember Lukey. Great questions. Councilmember Sales.
Could I speak to that just
Yes.
a moment? A couple of things that I noted. Your comment about the forums and who they're reaching and who they're not. A lot of the parents and the students who are coming to these forums are coming because they heard Dr. Kapunen's message, they heard it in the media, they heard it at school, they heard it here, and they want to know more because they didn't know anything. So we are getting that outreach, and the media is being very good about helping that. And I put conditions on all the interviews: no syringes, graphics, or anything like that that can trigger somebody, and appropriate language, non-stigmatizing language. And I will talk to anybody, and they can write about it as much as they want. I share a personal story. This is personal to me. I have been through this with my child. Fortunately, he's 7 years in recovery. Not everyone's that fortunate. Dr. Kapunen and her staff have been amazing. And so that really helps. Sending out that message got a lot of people saying, what happened in Montgomery County that made you do that?
Right.
It's happening in your county too. It's happening everywhere in this country, but we're talking about it and we're at the forefront of that. And that's why I'm so pleased to be here and so pleased to be at those forums, because I know what happens when you don't talk about it. I know what happens if you don't deal with the mental health issues. I lived it. My family lived it. And I have a granddaughter who has mental health challenges and other challenges, and I'm determined to avoid that same path. But for those that we've missed that prevention window, we have to make sure that there's a treatment window and recovery path as well. In terms of the discipline, we know already that we can't arrest or suspend our way out of this epidemic. It's not possible. It's a mental health and substance use issue. Those are both medical issues, and we have to treat them as such. So I would hope that there are supports for the family and for the students and diversion programs. Stephanie Izzard in Dr. Kapunen's office helped to develop the SUPRE program, utilizing that where it brings the student and the family together to do some work around understanding each other and understanding the extent of their substance use as well as mental health issues, and getting them referrals as they're needed. And I hope that we won't differentiate based on substance, because vaping is no better than smoking any other substance or injecting any other substance. It's all related, and it's trying to numb or fill a hole. We have to treat it the same across the board, or we send a very different message than this is a mental health or substance use medical issue that we can help you with.
Thank you, Ms. Mitchell.
Thank you.
Yeah, thank you. And then before I turn to Ms. Sales, I just do want to mention, I meant to mention it at the front of this session. You know, I was speaking with Dr. McKnight a couple days ago. We are on the cutting edge in the state. You know, other jurisdictions have reached out and saying, you're sending these messages, you're having these forums, and they're reaching out to us saying, how are you structuring them? What are you doing? That's a good thing, but we have our own standard here, and we often lead in this area. So I do want to thank MCPS for jumping on this the way they did, and obviously we have a lot of work to do, but that is a good point. And thank you for sharing your personal story and all the work you're doing.
I didn't introduce myself. I'm Laura Mitchell. I chair the Alcohol and Other Drug Addiction Advisory Council, soon to be Drug Addiction. We're changing the name to erase the stigma. Hopefully we'll do that. And I chair the Substance Use Prevention Committee for MCC PTA, the countywide PTA agency, and I'm the VP of Advocacy for them. So, and co-founder of Montgomery Goes Purple. So I'm all in on this.
Yes, you are.
Send anybody to me, and we will give them the secret sauce formula. It's, you know.
Thank you. Councilmember Sales.
Thank you, Mr. Chairman. So again, another display of incredible programs that we have implemented across MCPS, and yet we're still seeing, you know, quite a few incidents of opioid overdoses. And so, you know, we talked about having health and wellness centers. They're in half of our high schools, I believe, and we're talking about expanding them to all of our high schools. I see that they're also in our elementary schools, and so wanted to know more about how we are coordinating with our health and wellness centers to use these as areas to deploy resources, to you know, concentrate training, and then how are we utilizing not just the health and wellness centers, but also our CEOs, the re-engagement of our CEOs to increase prevention, training, and awareness, since it's my understanding that they are in rooms until there is an issue, but we still have issues about bathroom incidents. So what's going on with patrolling? What are the requirements? And, you know, I think Councilmember Lutke made a good point about, you know, the immediate repercussions. When an incident happens, it's easy to have, you know, these family meetings or these follow-up events, but an immediate repercussion. Not necessarily, we're not criminalizing the behavior, but we want to address it immediately. And, you know, one of these interventions that Councilmember Lukey mentioned, I mean, that's what in-school suspension was for. You know, when you got suspended, my parents had to come to school and walk with me to every class. It was embarrassing, and it limited the amount of times I got suspended. It deterred behavior. So what are we doing to immediately reinforce good behavior when these incidents, when students are found in the bathroom, when they're late to class, loitering, because we're not just finding the drugs, it's guns as well. So just wanted to know what we're doing with the health and wellness centers without recreating the wheel, but the resources that are already available to us.
I'll speak first to the health and wellness centers, and just to lay some ground definitions. Every school has a health room, right? School health nurse, school tech. Every single school has access to a team that knows how to use the Narcan and that we partner with. They're the ones who help do the training in the schools, in addition to Mr. Stevenson's team from Prevention and Harm Reduction Services. So school health nurses are very involved already as first-line providers and supporters of training in the schools. We have comprehensive health and wellness centers. So those are the school-based health centers and school-based wellness centers, currently in 14, soon to be 15 schools. And those provide both mental health services and comprehensive physical health services, mostly to students who are not who don't qualify for public assistance. So a lot of that is primary care services. So as part of the services they provide, when they do a well visit, they screen for substance use. So they can connect to services in the county like CAS, SASCA, like the Montgomery County Crisis Services, and they can actively screen for substance use. But not all schools have that comprehensive physical health suite. That is limited to the school-based wellness centers. Now, in the additional 19 high schools, that's only in 5 high schools. So just speaking to the high schools, only 5 high schools, soon to be 6, have that comprehensive school-based wellness center. The Bridges to Wellness that has been introduced at 19 high schools this year. So this is something that's just happened in the past 4 months or so, or 4 to 6 months, have the mental health services component. So as part of the mental health infrastructure that I spoke to earlier, substance use is something that comes up in those spaces along with the other mental health things that we are seeing. So when that's the conversations we're having now is what additional substance use screenings, how does the referral system work? We have multiple partners in that space, and DHHS can speak more specifically to individual vendors, and you've heard about this in other sessions, just to really align how we think about substance use screening in schools. This is also one of those spaces that Montgomery County may be leading the way in terms of systematic, comprehensive substance use screening. It's not something that is happening in every school district, but how we use our mental health infrastructure, including our new Bridges programs, to incorporate this into their mental health screening and referral techniques, as well as identifying what types of interventions, brief interventions we might be able to do as part of the school engagement process, is how that connects to substance use prevention and response. And I can...
When I was a principal in Montgomery County, 12 years, my frame of reference for what you were speaking of was when a student was suspended, they didn't go back into class until they had a meeting with the parent and the principal. It was called an intake meeting. And then I think about the what we've implemented over the past several years, especially from the model policy through the state of Maryland, has been supportive measures plans, with safety plans, with any incident, whether they're offender or whether they're the victim or alleged, either way, that we have measures in place, not only for their safety and the immediacy, but also that counseling element as we follow up weeks after. And so, as Dr. McKnight mentioned last week, when she spoke to the media on Wednesday about re-engaging our parents, she was speaking specifically about the hate bias, and if they were involved in any type of hate bias incident, you know, bringing in the parent with the offender and having a conversation. And so that's where my frame of reference and our frame of reference is changing now. It's not just for suspendable offenses where the parent comes in and we have this intake conference, but how do we have that reentry program back into the programs? Whether they were suspended or not, whether there was, you know, any type of discipline or well-being supports, mental health supports, setting up, and we're in the process of setting up that structure so that we have these reentry meetings, even if, again, they weren't out of the building, but they're reentering back into the day-to-day programs of classes and activities, having those meaningful conversations with parents to be able to and their students to be able to collaborate together. And then at the table, what resources do you need from the home? What resources do we need here so that we're successful for your child? And that's where we are moving towards, not only just with hate bias, but with all of our circumstances or situations that involve our students in these problems.
And I think the last part of your question was around the CEO program. So that program is less than a year old, and so one of the things that we are doing right now is working with Captain Satinsky and our law enforcement partners to just kind of revisit that and look it over and see if there are changes that need to be made. But again, the program is less than a year old, and so you know, I don't think that there's a burning desire to completely recreate the program at this point, but to really look and see where it could be strengthened and where there might be challenges that need to be addressed.
Just to summarize, if it's okay, I think what we're talking about essentially is where are all the different spaces and situations in which we may recognize kids who need support through our wellness and health centers, through disciplinary action. If it turns out, they come to our attention in that way, if they come to the attention of a community engagement officer, and we just have to hit it across the board, including being proactive with parents and youth so they feel empowered to come forward. But all these different entries to resources and support have to be addressed simultaneously. So I appreciate the broad overview and approach of your question. Thank you.
I totally agree, and like the idea of actually having trained ambassadors at each of our high schools, because you're right, we do have health centers. They may not be the traditional new health and wellness centers, but we have health centers. My last question, because all of our students are on social media, how are we using social media to better target our students with prevention and awareness and educational information, and how are we promoting this in our schools with posters and promotional materials? I yield.
So more to come from our excellent communications team, but this is something that we're working on with input from a youth advisory board, is how will this messaging look in the way that youth need to receive it. So one thing, as a pediatrician, we often speak to parents, or we put out messages to adults in the community, and that may not be what youth need to hear or how they need to hear it. So your question about social media is extremely important in terms of using youth input to package messages, understand what is important for them to know, what their experience is, and how we put that out. So that's something that we're certainly working on, but also why the youth ambassadors and empowering and engaging youth to work with us in this space is so important.
Thank you. That's great. Go ahead.
Sorry, that is a critical piece. You can go online and get a menu of emojis to order drugs delivered to your house like a pizza. But you cannot go on any Montgomery County site and easily get a searchable locator for services. And they're, even if they were there, and we're hearing that they're not. We also, I don't want to forget the students who suffer in silence, who aren't the ones that are getting those referrals to the CEO or to RJ circles or any of those things, the ones that put a lot of self-pressure on themselves. And you don't see them as anything except for a shining bright star until they can't anymore. We have a lot of those. Yeah. So we have to identify ways to help them as well and make this available everywhere. But those resource finders are critically important because we have a lot. We don't have enough, but we have a lot. But people don't know how to access them all the time. And the AODAC, one of our very first our top priority is the needs and gaps analysis. And working with LBHA, they're starting their needs assessment. It's quadrennial, I believe, that to look at what are the needs, what's the extent of those needs, what do we have, what don't we have, and who can we partner with to get them. A P3 like we did with Avery Road for youth services, co-occurring mental health and or substance use issues, I believe could sustain an operation, a regional operation. We don't have anything in the state when you get to the level of residential. If it requires county money, state money, whatever that requires. My feeling is it's government's job to do the things that private industry can or won't because of barriers to entry and costs to sustain. Yeah. That's where we have to step in, and we have to be willing to do that. If we really want to solve this, we have to do that. We have to look at children and families who have lost a parent to substance use. They are at probably the highest risk of anybody. Let's have summer camps to help them process that. Yeah. Let's get handled with care out of the general counsel's office and on the streets, and mandate that our officers be reporting when they have contact with a student who's been traumatized so that they can get trauma-informed care in the school. If we deal with it, treat it properly, then it does not grow.
Yeah, I appreciate you saying that. Councilmember Katz and I were just in a school last week where one of the main requests from the leadership was a place that you could have co-occurring mental health services like embedded in the day for kids that needed, there's varying levels, right? Some don't need residential, which we don't have either, but some could use it where it's a part of their daily curriculum like we do with other programs like autism or other, where it is embedded into the day, and we don't have that now, and I think it's a gaping hole, to your point.
Youth peers, support groups, AA groups, NA groups, any of those things in the schools would help. Students carrying Narcan, I have a list for you.
No. This is not the last, and I want to make sure we get to Councilmember Mink, and then we bring our police officers up. Can you hold, or is there a quick point you wanted to make?
I just wanted to plug the MCPS Stronger Student app. I know that was mentioned
yes,
earlier.
the students create it.
It's on their phones.
Yeah.
They can download it for free. It has direct connection to DHHS resources, the Crisis Center.
Stronger Student app.
MCPS Stronger Student app, the suicide prevention line, all of our reporting avenues. So.
Thank you. That's a good point. I meant to bring that up too. Councilmember Mink.
Thank you. Thank you all so much for your work. And Laura, thank you for those great insights. That's very helpful. I wanted to just mention quickly the relevance of MCPS staffing issues to this whole conversation, because there's so many different elements here where having enough staff is critical for being able to be all hands on the deck in the way that we need to, for covering bathrooms. And I have heard from many students and families who bathrooms have been locked in areas where it would have been the most accessible and the closest bathroom, and then we've got students who don't have time to go to the bathroom, or makes them late to class because they're running across. And I realize that is presumably a staffing issue. If we're not able to keep that bathroom safe, then we're closing it. But of course, that's not a situation that we want to be in. So doing whatever we can to ensure that our schools are fully staffed up, that we're doing what we need to do, that we're offering the salaries that need to be provided. We want to support you in that, and that's just going to be incredibly important. And that also goes for our counselors, being able to provide mental health support. Our counselors in schools have enormous caseloads, and sometimes very urgent cases from students who are requesting care, who then have to wait for many hours and sometimes days. So I think just staffing, we have to be putting everything that we can into that, especially at this critical moment. We heard from Mr. Stevenson about the importance of having Narcan administered immediately. Are we tracking how many Narcan kits are available at each of the different schools?
Mr. Hodge might be the best person to answer this question, but as part of the Narcan program that was set up in response to the state requirement, we have to report each episode of Narcan, and we have to use, I think it's a minimum of 2 doses, and we have more than the minimum required doses in our schools. So we do track them, and that Narcan expires, and it's something that needs to be inventoried and reported when used.
We're tracking that we're meeting the minimum of 2 doses, or we're tracking how many are in the schools? Because there's a wide range from what I'm hearing.
So there is a minimum number of doses. You have to staff it. You have to stock it in schools. We have more than the minimum is required in secondary schools. Students may have, and other people may carry it that we don't know about. And what we're looking at now is who are we intentionally training? The CEOs have access to it, but looking at other MCP staff and being more intentional about the spaces in which students are. So, athletic trainers, for example, or people who are running after-school programs. And some of that is already built in that principles identify who are the additional MCPS personnel who get the hands-on training, and also identifying where they at. So it actually might be different. Some schools have over 3,000 people, some schools may have 1,000. So the exact number may vary according to the student spaces and the population.
Thank you. So I recently had the chance to speak with a high school principal who had taken the initiative to request a Narcan training be made available for the entire staff, and dozens of teachers and staff participated in that. And they informed me that all of the department heads now have Narcan kits in their offices. So that means that, of course, now they're much more spread across the school, ready for a faster response, and there are more people who are trained to be able to retrieve and to use it. So there definitely is a really wide range, to your point, of whether schools are meeting that minimum or going far beyond it. So do we have, or are we tracking specifically, like this school has this many trained staff or other personnel with Narcan kits and so on?
So when schools participate in the official training process. That is the baseline guidance for additional personnel. The additional personnel who are trained, all of that is kept by the school health room, who is responsible for doing the training. We've seen a lot of interest amongst school administrators and individual communities to have above and beyond that. So part of the Narcan policy that is currently being drafted is to really understand where those training records are kept. And part of this is also working with DHHS to understand what the resource is to be able to provide that level of support to every school.
If I can just pick up on your earlier point about staffing, I would just say that we really agree. We fully agree with you. So last Thursday, our board adopted the proposed budget that will be sent over to this council and the county executive this Wednesday. It is a budget that we feel puts the resources forward first for our staff, to provide them with the salaries, the benefits, and the resources that they need to be successful and want to stay with MCPS. It also adds additional staff around security, around recruitment, as well as math and literacy supports for our young children. But it's going to be critical that we are able to fund that budget, because that will directly result in the types and the quantities and the amount of services that we are able to provide for our students and for our communities. And so I know that I've been in conversations with several of you already about the additional burden that is on our school system today that wasn't there 10 years ago and 20 years ago. And for us to effectively address that, it is going to take additional resources. And so I thank you for that question, and I think I agree, and I think I speak for the superintendent when I say, yes, we need fully staffed schools with high quality leaders and teachers and support staff in all of our buildings.
Thank you. And just to return to the number of Narcans that are in the schools, it seems like that would be really helpful numbers to get, and we could probably get them just by asking the principals to report, if they have taken the initiative to hold those trainings, or their school nurses have, and so on, because then we can find out where we have schools that are having issues and they don't have, as many Narcan trained folks and staff available. That's something that we should remedy. We're not going to be able to identify those holes if we're not collecting that information proactively.
Absolutely. And then also defining together as a clinical services team, what is the number of safe doses of Narcan to be in? Does it really need to be in every single classroom? What does access look like? What does equity look like when we're talking about having enough Narcan to distribute amongst 210 schools? I think is also really important. And that's why we're trying to be thoughtful about who really needs to have it, where are students, how many students, where are they located?
Absolutely, thank you. Yeah, and if we're looking at 2 doses per school, and our schools have very different populations with very different needs and numbers, that seems like we're probably falling short in that. So that's great that you're looking into that, and hopefully we can get that information collected quickly.
And also that we have above the minimum 2 doses in our secondary schools.
Yes,
yeah.
Thank you, appreciate that. Laura, did you have a?
Yes, please. Sometimes it can take more than 2 doses for one person, and there may be multiple persons at the same time. So, but another thing to think about is the size of our schools, the distance between where that child is found, and you don't know how long they've been down, and the nurse's office and back and forth can be the difference between life and death. So one of the requests that I brought forward is putting these in the AED kits and co-locating them with AED and bleed kits, not just in our schools. Remember, this is a community problem, but in county buildings, in every public building, at pools, places where people are that may need to use it. And if we can do that and put that out, then people will know. One person said, what if it gets stolen? Well, then we replace it. Obviously, that needs to be monitored and watched for expiration and for use and all that. But if someone needs it and it's taken out of there, then that's a life saved, in my opinion, and I would like to see that in every one of our buildings.
Thank you.
That's a great point. Thank you. And then I just wanted to ask also, I've heard from students who participate in the program with MCFRS that allows them to be trained as EMS technicians, that they are getting Narcan trained, which is awesome, but that they're not supposed to carry that Narcan or administer it in schools, and it seems like that is a huge missed opportunity.
There's no policy currently that states students cannot carry Narcan in schools. We have an emergency medication policy that allows students to carry emergency medicines prescribed to them by a physician for a diagnosis they have. This space of having students administer medications to other minors is a new space in which we need to be thoughtful about what our policy is and how we support that in the most responsible way, as with other harm reduction strategies. So we certainly have every interest in empowering students to use this resource. We are just making sure that we do it in the most responsible way possible, because we don't really have a precedent for having students intervene in an emergency circumstance for other minors in a school space, and we want to make sure that they understand that we have emergency procedures, and it's so important, if this is happening in a school space, to recruit all the responsible adults who are trained in part of the emergency safety plan, and also to educate students on what that emergency safety plan is, because that's another thing we're hearing from the same spaces, is some of them didn't know that there was Narcan in the schools, or how to, alert the emergency system if something's happening in schools that they mentioned. So all of that has to do with responsible harm reduction, and it's not something that they're purposely not allowed to have.
Sure. Thank you. And, okay. All right, we're gonna move on.
Yeah, thank you. Thank you all very much. We could talk all day, but this is really helpful, and I'd also ask you to stick around just in case. We have delayed our state legislation until 12:45, so we have 45 minutes. If the next panel can stay that long, I hope they can. So thank you all from MCPS, and just stick around for a minute. Would ask Chief Jones and the fire team to come on up, and thank you for being so patient. I understand you all don't have a presentation per se, but I'm sure you'll make some comments, and then we can get into questions. So we have Chief Marcus Jones, Assistant Chief Nick Augustine, Captain Pizzarino here, I think, Captain Jordan Staninsky, Battalion Chief Ben Kaufman, and Vital Graves, the Program Manager from the Emergency Medical and Integrated Healthcare Services Unit. I saw Dr. Stoddard. If you want to join, you can. Appreciate everyone for being here. And Chief Jones, I'll turn it over to you.
So good afternoon now to the committees.
That was so.
I think you did it as the clock changed too. So
it's all good, right on time, right on time. So thank you all for having us. And we'll have some brief comments just generally. One of the things I think that is most important in this discussion is really from the police department's perspective, and working with our partners at HHS as well as MCPS as we deal with this crisis of overdoses in our community with our youth, is that we really have always taken an approach of education, prevention, and enforcement as the last way of addressing this. And the enforcement piece I want to emphasize is really looking at the distributors of these illicit drugs that are harming and killing people in our communities, and I want to talk about the strategies on how we address that. But as we look at much of this, of the things that are centered around prevention, and what we've been working together with HHS as well as MCPS here recently with the projects that the forums that they've been having. But we've been, this problem has been around for quite some time, as has been noted by many of the council members this morning. We've been dealing with opioid abuses for over 10 plus years in this county. Looking at it in a very serious way, in a variety of different ways, the way the drugs have been distributed over time in the illicit drug market. And this is a national, international problem, to be quite frank with you all, as this is impacting Montgomery County. We have, again, going back and coming up with different strategies, and we still have things that are impactful today. We've done historically drug take-back programs with the DEA twice a year. That has evolved into every district station now having prescription drugs, take-back boxes that are in the stations. People can bring them in at any given time, 24 hours a day, drop them off, put them in a box, walk away, no questions are asked. Those boxes exist. And we also, looked at, how could we also be out in front of this from an educational standpoint to all of our community. And so we, with our partnership with our the Montgomery County Police Foundation, we were able to work with them to create a opioid trailer that goes around to the different schools in partnership with MCPS to help educate adults and family members. And we don't allow juveniles to actually go in to these trailers because we're actually trying to educate parents really on understanding where that individuals will tendencies to hide these prescription, whether they're prescription drugs or illicit drugs, regardless, that we find ways to try to really communicate with them so that they are clear on this. This trailer has become so popular, particularly after COVID has ended, that we're now in talks with the foundation to create another one in order to be able to now to again push this out more to educate our community. One of the things that I have continued a focus on with our approach and how do we address responding to overdose cases. And I want to make sure this is clear because there was information brought up about the data, that everyone understand that the police department is not always called to an overdose. That there are times we do not get information. If there's someone goes directly to the hospital, as an example, we would not get notified that this overdose has occurred. So our numbers look different than I think that you see that's distributed in the state, as discussed earlier. But what we do is we do make a concerted effort when we do respond to a location, particularly a residence, and how we address an opioid response. We have a policy that I send out a narcotics investigator to every overdose case that we have in the county, regardless of age, and regardless of where it is. And there's the focus, again, is not to have an enforcement effort on the individual who has in fact overdosed. Hopefully that individual has survived, transported to the hospital to receive the services that they need. But we're there to actually collect intelligence. In fact, to try to gain information that's going to help us to look for those who are distributing these drugs in our community. That is our main focus. We are partner and have partnered with the Drug Enforcement Administration from a federal standpoint to look at cases both nationally, regionally, as well as internationally, because we know that there are organized groups, as noted, as was described by HHS well about how these drugs are amassed in our communities, that they're not necessarily designed that always they are just simply fentanyl. And I'll have Captain Paserno, who oversees our Special Investigations Division, give a little bit more in-depth information. For example, he has detectives assigned to the DEA task force in order to help us with these investigations as we move forward. We have successfully identified individuals in the past who distributed drugs, who have actually caused individuals to die in this county. We have charged them criminally with our state's attorney's office, charging them with the manslaughter of those individuals who have died. We will continue to do that. That is a focus that, again, to show the seriousness about how we take in regards, because again, we're looking and trying to identify the ways and means that these drugs have been coming into our areas. We've seen so many different sort of transportation routes in which these drugs have come into. They've come through Baltimore. They've come through, again, from our northern parts of the country, as well as our southern and western parts of the country, that have been directed and come directly here to be distributed onto our streets in this illicit market in many variety of ways. So I just wanted to really, again, we're also, one of the things, even in our partnership with DEA, that and in fact, I just met with a special agent in charge just last week. We talk about our partnership with the U.S. Attorney's Office to focus on these major distribution networks. And again, if we're tying these cases to any deaths, that they will be supporting us as well. So again, I just wanted to focus on that. I have Assistant Chief Augustine with me this morning to also talk about our crime lab, what we're seeing, some of the statistics that we are seeing with the crime lab, because we are getting these pills that are, again, are disguised as Percocet, as Adderall. And then we're looking at the actual analysis of these chemicals that are in these drugs. We are finding in a large portion, in a majority of these cases, we're finding fentanyl. And that's the danger zone, and that's where our DEA is making their comment in regards to one pill can kill, because it only takes a little bit, as we've noted. So I'll turn it over to Assistant Chief Augustine.
Good afternoon. I'll just be very brief on this, but since the epidemic over the past year, with all the drugs being analyzed at our crime lab, we have seen over 80% of the pills coming in having fentanyl in them that are not suspected to originally be fentanyl. They're being masked to be another prescription medication. And as we look at this on how we educate our officers, how we address this issue when officers see certain medications on the street, and understanding that what they typically look up in a pill identification, and it's important to also let parents know this and our community know this. When you look up a medication and you think it's a certain thing because you went to the internet and looked up the pill, it may not be that. And that is something we haven't seen in a long time, especially at numbers being over 80%. And it's concerning, but that's a message that needs to get out to everyone. Just not take it for what it looks like. Make sure you know the source it is coming from, whether it's a pharmacy or a doctor. You know what you're getting, and just don't have a friend give you a medication because they might not know what's in that also, saying, hey, can I have a pill for this because I have a headache or whatever. It's an important message to know the trusted source, and that's confirmed source, so there is no accidental or intentional overdoses occurring due to the dangerous of the fentanyl.
Thank you. Anyone else? We can turn to questions if no one else has a comment. Yeah, the questions? Okay, appreciate that. And that's a good point you bring up, Assistant Chief Augustine. Councilmember Katz and I were just talking about that. You can literally buy the things that look like actual medicine, which we saw online, and so it's a different time for sure. I will actually start with colleagues first, and since we have short time, and then I'll if there's any time left, I'll ask a question. Start with you, Councilmember Katz.
Thank you very much, and thank you for again, thank you for all that you're doing. You know, I guess the question that I had asked earlier is, how are we working together with the various departments, with Montgomery County Public Schools, with HHS, and I understand how you're trying to figure out the sources, but are they communicating? How fast can they communicate that something has happened and that you all can look into the sources?
Yeah, significant challenges, right? I mean, you know, it takes a lot of legwork, to be quite frank, unless someone comes out and literally provides us with information right from the very beginning, which is not always the case. So it does take a little bit of us, again, getting the information as quickly as possible to start the wheels turning, you might say. But I will tell you, I think HHS you know, again, and everybody's roles are somewhat different, but then there are alignments there, right? With MCPS, you know, when we work with our school, within the schools, if we have an overdose within the school or in the school community, we're communicating within to make sure that they are aware of the significant challenges that we're seeing. Now, again, sometimes from an intelligence standpoint, we know of individuals who are selling these drugs in our communities. We don't necessarily know who the buyers are. So in cases where we don't know whether or not you have that there is specifically targeted school-age kids, as an example. Sometimes, you know, again, because they're utilizing different modes of social media communication techniques, that it makes it very difficult for law enforcement to sort of track that that communication trail. But, you know, the intelligence gathering is very important in this. What we're seeing, what everyone else is seeing, sharing those thoughts together, I think it's really, that is going to be a key for us to be able to fight against this in any community in which we're having, in which we know, as it's well shown, that it's all throughout the county.
And obviously the Good Samaritan law is an important law and is a necessary law. But if we have, and I know you've had this, and Montgomery County Fire and Rescue certainly has had this, you've had people multiple times in a week overdose. And not that somebody needs to be arrested, but somebody needs to help that person so that stops. So it turns to Montgomery County Fire and Rescue when that happens. What's the next step? Do you contact somebody to say, at this address we've had X number of calls, and how can we help that person?
Yes, thank you. My name is Avital Graves. I run the Mobile Integrated Health Program for Montgomery County Fire Rescue. So we work really closely on data surveillance. We rely heavily on a system that can cross-reference data from multiple sources so that we're able to determine when those repeat overdoses happen, as opposed to having one person kind of continuously read through reports. That information is also shared with the STEER team, who runs out of the Maryland Treatment Center at Avery Road, and their peer support counselors. And so in partnership, we work together to share names, contact information, etc., so that the STEER team can actually access that person while they're in crisis, hopefully. They used to be able to access them very easily in the emergency department before they hopefully absconded, so that they could offer them resources and support. And we've seen firsthand that the peer support counselors are so much more effective at getting people to accept help than paramedics or EMTs are, just because they have that lived experience. So we continue to do that. They get the emails as soon as they come through the system. It's usually within an hour of the paramedic or EMT completing the report. And we have a separate one that tracks repeat overdoses within the last 365 days. So if someone has run multiple times, we will see that as well.
Good. And I'll stop on this one, but if you all could, if you knew of a better system, of a way to enhance your system, I'm saying this to everybody, I'm looking at you, but I'm saying it to the world here. If you all know of a better system or a better way for us to correct what is going on, please do not hold it. Please tell us. Because many times people who are actually doing the work have a better idea, if they were in charge, what they would be doing. And we need to hear that. And you know, so please let us know that. And I am just going to speak for my friend Dr. Stoddard. I know that Dr. Stoddard would want to hear that as well from the people across the street. We need to figure out the best way possible. If it's not here now, let's figure out what can be here. So thank you.
If I may, I want to chime in here because I think it's appropriate. So we do obviously have these opioid abatement funds. They're going to begin coming to the county. They actually started arriving at the end of last year. The opioid intervention team has been meeting, and actually Ben Stevenson organized a great conversation just last week with regard to what resources do we have in front of us, what resource gaps do we need, talking with the entire opioid intervention team. I believe so far we've received approximately $1.6 million. There's about another $200,000 from a different bankruptcy that we're expecting shortly, and then the state has received approximately a little more than $24 million, of which we believe somewhere in the area of $3 million will come to Montgomery County, which is
a substantial increase in the opioid-focused resources that we're going to have. Obviously, those are one-year funds with there'll be different allotments each year that are not necessarily equal. But obviously, we're looking at those new resources about how we can up our game and up our coordination across multiple agencies. And so that will come across as a supplemental appropriation. We'll need that, so we'll be having a conversation with the council about that. But these are the exact conversations we're having with our opioid intervention team.
Appreciate that, and I appreciate your answer on the data. It's good to know that's happening. The one question I did have, since I will sneak in since you addressed it, you have data in the packet from July to January about overdoses, but it stops, the lowest bracket's 18 to 24. So for those youth, so those below 18, that's captured where?
Yeah, we do track, I'm sorry, I didn't see the packet beforehand.
That's okay.
But we do have data on every age range. Any patient that we run of any age who we believe has a suspected opiate overdose. We don't determine that someone has overdosed. We allow, tox screens or whatever it may be to determine that. But we have our triggers suspected. So are they unconscious or unresponsive for an unknown reason? Does Narcan work? Then we suspect it was something related to opiates that we were able to
intervene. And so you do
with.
track that for youth?
Yeah.
And so there could be some overlay. I'm looking at Mark Hodge of like what those numbers are. Where, where does that happen? Where is that discussed, and what's your part of that conversation?
So Fire Rescue is part of the Opiate Intervention Task Force with Dr. Stoddard and the rest of my colleagues here. We work really closely every month to report and share data on Narcan administration and suspected opiate overdoses that Fire Rescue has run. So we provide that data on a regular basis. We're also part of the Opiate Intervention Fatality Review Team that's been mentioned before, and so we'll talk about where that goes. And that does deal with adults 18 and up. But if anyone needs data on where we're running things, how many we've run, and to people's points, people aren't overdosing in the streets. They're overdosing in homes. They're overdosing at the schools, as we know. But it's a private matter. It doesn't happen out in the public view in front of everybody.
So just as follow-up, I want to make sure that we're having that space. Sounds like the space exists, but it could be a little more robust and a little more delving in for the youth population. So this one,
I would agree, Chairman Eduardo. I think what the evolution with youth we've seen has been the most shocking thing about it. We've had this opioid intervention team for years now. I was actually one of the co-chairs with Dr. Kroll when it was created. It's evolved substantially over the years, and I think the evolution of the last year with regard to youth overdoses has caused obviously great consternation, but we have to evolve our strategies, because what works with adults does not necessarily work as well with young people, and I think that's where we are moving to adapt.
Appreciate that. Councilman Roberts.
Thanks. So as was noted, this is an international problem, no question, and we're dealing with the repercussions of it right here at home. But I know that the level of sophistication and the selling of these drugs is a wide range. And I have participated as a parent, and my second child is about to become a teenager, so I will have 2 teenagers very soon. And it was so sobering. And I went and checked out the presentation where you can see where they might hide things within their bedrooms. I encourage any parent who has the opportunity to participate in that kind of training to do so. But the issue of communication, so Snapchat and some other forms of communication, which I don't think parents fully realize how dangerous those forms of communication can be. Could you talk a little bit about, from police's perspective, just some tips to give to our broader public? And by the way, I know that a number of our colleagues wanted to join, but there is an announcement made later this morning. We're hoping that, regarding a transportation initiative, we're hoping to utilize this work session as a launching pad to better communicate to our public. But while we've got you here, what tips would you give to parents we know that we want this to be the final stage, but if you suspect that your child has come to you, or you are a coach, or you are a teacher, and a child who has trust with you says, somebody has tried to sell drugs to me, and they don't know where to go or what to do with that information, what tips would you give? And then what resources would we give to those folks? Who should they contact within MCPD? Because 911 is just is too much of a catch-all.
Yeah, so we have a drug tip line that we've always had, and there's also the ability to also text to provide text messaging along the way, even in our 911 center. And, you know, there are ways to do this anonymously. You know, we don't always require people to leave their information, but to share information, many people will just leave it anonymously, and they'll provide as much information as they have to share. So we encourage that from that perspective. You know, we always are looking for new ways to really create the ability for people to provide complaints, as we have done over the years with different crime tips that come throughout our community. So we want to be able to, in fact, I know as we talked about some language issues, one of the things I am working on, we're finalizing hopefully within the next few weeks, is to have our PIO Latino liaison that will again be able to help us to communicate in a larger community sense, to provide those sorts of those reaches. I'll allow Captain Paserno, who oversees our Special Investigations Division, who does these investigations and knows and how they handle a lot of how individuals are communicating in many of the social media channels to talk about their challenges and how they address them.
Thanks, Chief. Good afternoon, everybody. Nick Paserno, the Director of Special Investigations. So under my division is our drug enforcement sections, in addition to some other investigative units. And the idea of the complexities of social media isn't just, you know, as you know, not just drug related. I mean, it touches every facet of the public health space, the law enforcement space, and we certainly do see drug distribution being done across social media. We see a lot of other crimes being facilitated by social media. I think that's part of a much greater conversation families need to have with their children about access and how you know, it's a powerful tool in a lot of different ways to encourage interaction. It also has its significant drawbacks and risks to it. So you know, the department has a lot of different resources for information for parents, from a drug aspect, in addition to, you know, all other types of crimes that could happen, facilitated by different kinds of social media.
Thank you, I appreciate that. And again, I know we're going to have an extended conversation in the very near future regarding security as a whole. I'll note, and I know Councilmember Lutke can appreciate this in particular, our judicial system plays a role in all of this as well, which adds another layer of complexity to these cases. And we've been working proactively with the state's attorney's office to have a more holistic approach. But the entire system needs to be evaluated because it's sort of compounding the problem, and it's making things a lot harder for folks that are on the ground and for you all to be able to do your jobs. Last thing I'll mention is this element of trust, which we've been trying to build for generations now, frankly. But folks feeling comfortable to be able to come forward to law enforcement when something is happening in their community is paramount. And how we do that and when we do that is going to be critical. So I'll have lots of follow-up questions when we talk about the school security issue, but for now I yield back to Chairman Jawando and appreciate all your leadership on this.
Thank you, Chair Arbonaz. And just so you know, to my colleagues, we're going to go in. We have a hard stop at 12:40. So Councilmember Lutke, and then Councilmember Sales, and then Councilmember May. Thank you.
So just a quick point. The Safe Schools Maryland tip line, anonymous reporting system, that is something that kids, parents, anybody can use, where they can take a screenshot, and they often do, and then they upload those screenshots in, and they're able to report anonymously. They can choose to include their name if they would like to, but they don't have to, which is a great way to get the see something, say something out there, or for a student who knows a friend may need help but doesn't know how to go and ask and feels uncomfortable with that direct contact, they can put it in there, and then it does get out, and the other student would get the help. So I have 3 questions for you. So I'm going to ask them all at once, and then you all can choose among yourselves who's going to answer them. One is to talk about how you all work with the Baltimore-Washington HIDA in solving the opioid crisis here in Maryland. 2 is with respect to gang members and a new trend that has erupted since the change in age of arrest has been increased. So with the age of arrest in Maryland raised to 13, I've had some disturbing reports where gang members are using children under 13 and paying them to engage in conduct that they would have done themselves. So they may in fact be distributing drugs, but they are underage for age of arrest. And the third thing, and this is directed at our Montgomery Fire and Rescue Service, the number of EMS calls are approximate for MCPS related to substance-induced medical issues. So, whoever wants to go first.
So in response to the first two questions, we work very closely with HIDA in addition to a bunch of other federal partners as well. We have, like the chief said, the DEA has been a major partner with us. We actually have a pilot program where we can actually take cases directly to the U.S. Attorney's Office in Greenbelt with deputized detectives in my unit, where we can go directly to Greenbelt to file charges when those charges hit certain criteria they look for. HIDA has been a very important partner with us, both financially, intelligence-wise. We do feed information to them on our overdoses through several different portals to get information to them. They provide feedback back to us, and we work out of shared HIDA spaces. So they're a very important partner with us. In terms of your second question about the youth, it's a kind of a double-edged sword, I think. To one regard, from a on-the-ground perspective, we haven't seen a drastic increase in opiate sales being committed by youth. Most of the dealers we've identified are adults, which is a whole separate concern that we have. But we have seen youth under 13 being targeted to commit crimes on behalf of others in other spaces, in the burglary space, in the firearms trafficking space. So while we haven't seen that yet in the opiate sale space, we have seen that other places. To kind of piggyback on what Chief Jones said, this is one of the benefits we get from sending detectives to every single overdose, is we get this valuable intelligence. It's costly in terms of man hours. It's invaluable, and we can't necessarily put a financial cost on it. But when you have 270 overdoses in a year, that's a lot of response. And each overdose brings with it between 5 and 10 man hours of work associated with it. So it takes a lot of capital. But because we're able to go to every single one of them, my analysts estimate 70% of our intelligence on drug sales comes from non-fatal overdoses. And we're now one of the few major jurisdictions in the country that still does this, because, as I'm sure you've heard in many previous sessions, the staffing challenges faced by law enforcement is a nationwide issue. Other places have decided that's a place they're going to cut response, those non-fatal overdoses. We have decided to keep that up. And now we're approached by other jurisdictions nationwide that are faced with similar concerns of mimicking our response. So by being consistent with the last 5 or 6 years in this response, we're better positioned than other peers would be.
Can I just interrupt 1/2 a second? For those who aren't aware, HIDA stands for High Intensity Drug Trafficking Areas. We, in government, many times we have our own language, and sometimes we need to explain it. Thank you.
Yeah, that was my fault. Sorry.
Regarding your question about MCPS calls as the location, we do track location of every call we run. One of the benefits of fire rescue is we collect data on every possible aspect of patient care that we provide, as well as dispatch location. I don't have those numbers handy for you right now, but they're very low. They are low.
Okay, thank you.
Mm-hmm.
Thank you, Mr. Chairman. Thank you, everyone, for your contributions to this portion of the hearing. Just wanted to ask briefly about the STEER program, any successes that you can think of, and any opportunities to build upon for improvement. And the STEER program is the Stop, Triage, Engage, Educate, and Rehabilitate program.
Yes, the STEER program is a wonderful addition to the complement of programs offered by HHS and across the county. I don't have specific numbers, but again, the STEER team is part of the Opiate Intervention Task Force that we all participate in. They report monthly on their successes. They do follow people for 6 months after they engage. So even if someone immediately refuses their assistance and declines, they're still going to follow up with them for 6 months to continue to reach out and offer support. So we really appreciate them, and they are expanding. They're working on introducing peers who speak different languages and who can reach people with different lived experiences. So they have a wide range of support counselors.
So you mentioned that they report monthly on their successes, but you don't have any. Are you able to share some data for maybe the past year?
Yeah, I actually was able to. While Avital was speaking, I was able to, we report on this in our opioid intervention team regularly, so we get monthly data on the number of client referrals, the number of screenings they do, the number of referrals that are the patients they refer to treatment, and then the engagement they continue. And so what I would say is that the Lieutenant Rich, who's the director of STEER, talks a lot about the fact that the value added often with STEER is not just the immediate people that get into treatment right away. They form bonding relationships and they follow those people for a long period of time, and then they get them more engaged in the treatment over time. We're trying to figure out a way to better track the engagement, the long-term engagement that may or may not later lead to treatment, because it's bigger than the initial number. And so in any given month, they get between approximately 60 to 80 referrals, meaning people that are brought to the STEER team for engagement. Of those, I would say approximately 2/3 engage with the STEER, and then I would say about 15 to 20% accept an immediate referral for treatment from the STEER team. The remainder they engage with, and many people who are not willing to go to treatment right away are willing to be engaged by the STEER team and stay constant with them because they're a peer. They're not viewed as law enforcement. They're not viewed as a government person necessarily. They're a peer, and so. We can get you we keep data on all those things for a long period of time, and you can see the trends over time. They've been relatively constant. During the pandemic, we saw some reductions because they were denied access to the emergency rooms, which are often places where we get that engagement, but because of the pandemic, they weren't able to make those engagements. I also know, and this is a credit to the police department, Sergeant Matthews, who's really heavily involved in the CIT team, and Captain Statinsky as well. They're looking for ways to get more engagement between the STEER team and those mental health responses, because we know the overlay between mental health and substance abuse is significant.
Thank you.
Thank you, Councilmember Sayers. Councilmember Mink.
Thank you. Thank you all so much for being here and for all your work on this. Question first for fire rescue, the EMT program for high school students that I understand, I've heard from students that you're doing Narcan training with those students. Is that accurate?
I believe that's part of the program, yes.
Okay, great. I mean, that seems like potentially also a great recruitment tool for getting more kids into that program, because there's so much youth interest in being trained there. And so I think that it would be helpful, as I know that NCPS is looking into how we can responsibly do harm reduction and including our youth in that, but there might be some messaging, some synergy there that could come together to help get more of our students interested in that program, letting them know that they could be Narcan trained, and then finding a way to responsibly integrate that into our school's community with those kids as being youth ambassadors and youth supports there.
So there's separate programs from what we train a first responder. We have medication that we carry on the ambulances to respond to a 911 call. That's separate than the Narcan that we would distribute to the schools or the community. But the concept is the same. We identify that somebody has potentially overdosed and we give them medication. So the knowledge is important, sure.
Thank you. Wanted to check also on your availability of bilingual staff.
We're participating with several press initiatives, and we have a team of people that are able to speak both in English and Spanish to those different initiatives. Yeah.
Great, thank you. And as we lean into maybe more of those youth programs and hopefully, using that as a recruitment tool, then also making sure, obviously, that language is a big part of that too. Thank you. Let's see, for MCPD, the educational van that you've been using to help inform the community about the risks here. I just wanted to add that to the list. If we have all these different tools that are being provided by different departments, which is great, and we're trying to get to as many people as possible. But just whatever information can be shared widely amongst all of those different groups, including in regards to your educational van, about what information, what the curriculum is, what information is being shared, who you're able to reach, so that we are making sure that we're bringing all the information together to reach as many of the different sectors of our population as possible. And then wanted to check if you have quantitative or qualitative data that's been collected on who exactly you're reaching geographically or demographically, or in terms of, Laura Mitchell, I think, had mentioned some target populations that are really key that we want to think about. And this is a question for you all with that educational component, as well as for all the other programs that we're doing outreach with. But do we have information on who we're reaching, as well as any quantitative or qualitative data or feedback that's being collected to figure out what's working, what's not, what we should be leaning into more, and so on?
We collect on all of our community engagement responses that we do. I don't know if there's said quantitative or qualitative data that's collected on sort of the impact of that. I will say again, this is a growing, as we have been doing these presentations over the last several years. This is not just a recent process. The COPE trailer has been in existence for nearly 5 years now. So we are again trying to have that expansion. And again, I know I've been talking to people in the community about this very trailer who did not know that it exists, but it's also, sometimes it's about an issue that's out of sight, out of mind. Until it starts impacting people close to them or home, then that's when reality starts to set in. We've been messaging on opioid overdoses for a very long time, for over 10 plus years, as I know. So this is something that I think we have to continue to be diligent about and expand our messaging, and to really kind of see what's the impact of that, right? I mean, I think in regards to where we are with our youth, we're going to have to see what the impact of these programs that we all collectively put together, and how we target them, what will be the answers in the end.
Thank you. And I know we're about to wrap up, and I know that Dr. Stoddard mentioned that, I don't know if it's Dr. or Mr. Stevenson, but that you're pulling together all the different groups, and that seems like a really great component to include, what is the curriculum in these different pieces, the pieces that you're adding to the COPE trailer, the experience that you've had over the last years. Should we be emulating that in other places, and then vice versa, and so on? Thank you.
Thank you, Councilmember Mink, and thank you to all our partners. And thank you for staying, even though we didn't get to bring you back up. I think this collective conversation is important for us to be in the same room. I've asked Ms. Clemens just to put up on the screen the recommendations so they make it into the visual record from DHHS about strategies and MCPS, so that they could be seen. We are going to distribute these to all council members, and it's now all available on screen as well. And we're going to have a follow-up session. Obviously, we'll talk about many of these issues during budget, but we will bring this joint committee back after budget to see where we are and to hopefully have implemented some of these things and get some better data. And I just want to thank Chief and his team, MCPS team, DHHS, on behalf of all of my colleagues. This is really important. It's an all-hands-on-deck approach, and we want to save and prevent as much harm to our youth as possible. And I know doing it together, we can do it. So thank you all very much. With that, we are adjourned.